Mr. K.V. Rambabu, who is the guest of honor and the managing director, founder and managing director of Pulse Pharmaceuticals. I would also like to request Dr. Ketan Mehta, who is the moderator for today's evening, to join. And let's go ahead with the lamp lighting. Can we have there's a matchbox. And can I have Dr. Marwa coming in? Dr. Kakatkar, I invite all the faculty to please come and join us for the lamp lighting.
वक्रतुंड महाकाय सूर्यकोटि समप्रभ
वक्रतुंड महाकाय सूर्यकोटि समप्रभ
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
वक्रतुंड महाकाय सूर्यकोटि समप्रभ.
Thank you so much, ladies and gentlemen. I request everybody to take their places. May I request the audience to please come forward? There are too many vacant chairs and nobody likes talking to the vacant chairs. If you can please come forward and take the chairs, things will be better visible also. And it will encourage our speakers also. Please do come forward. The first assignment, ladies and gentlemen, I've been given is introducing our guest of honor, Mr. K.V. Rambabu, who is the founder and managing director of Pulse Pharmaceuticals. Mr. Rambabu is a commerce graduate and a first-generation entrepreneur. He has over 4 decades of experience in pharmaceutical industry. He started Pulse Pharmaceuticals in 1997 and has initially established as a marketing company, and today it has emerged as a prominent entity in the pharmaceutical industry, focusing on developing new, innovative, and novel drug delivery systems. Dexel is one of them, and we are going to be hearing from him also what it really means to him. I will also add here that under his leadership, Pulse Pharmaceuticals has flourished. As the founder and managing director, he guides the company's growth, operations, and strategy with a vision to provide groundbreaking products and enhance the well-being of the patients. I welcome you, sir, on behalf of Pulse Pharmaceuticals and AIG. I would not take long here and stand before you and the academic program. I also have the privilege of introducing and inviting Dr. Ketan Mehta, who is practicing as a consulting physician, cardiopulmonologist, and diabetologist at Mumbai since 1995. Dr. Mehta has been a past president of IMA, and he is the president of Mumbai West branch of IMA. He is vice president, IMA Maharashtra State branch. He is the honorary general secretary of IAC, organizing secretary of IMA and MS-CG-Con. He is founder president of AAME and Accord. And Dr. Mehta is on the editorial board of JAPI and the Journal of Medical Nutrition and Nutraceuticals. Dr. Mehta is a postgraduate teacher of FCPS medicine and is an ex-teaching faculty from the AIG-Pulse Medical College, Mumbai. Dr. Mehta has been involved in various clinical trials as principal investigator. Just to name few, they include TIPS 3, HOPE 3, TIPS, MARS, and TIPS-K. With these words, I welcome Dr. Mehta to this program, and I invite him to introduce our chairperson and take the program forward. Over to you, Dr. Mehta.
Good evening, everybody. At the onset, I would like to thank Pulse Pharmaceuticals and AIG for inviting me and arranging such a super program on the occasion of World Osteoporosis Day, which was on 23rd of this month, October. And now we all are celebrating as a World Osteoporosis Week. Friends, this is a program which has been conceptualized in a unique way, giving a concept of osteoporosis which is relevant to multi-specialties. And then what we are going to discuss about vitamin D and its relation with osteoporosis. And you all would be wondering, what about vitamin D? We have been taught right from our undergrad days talking about vitamin D. And that reminds me a beautiful quote from Sir Isaac Newton, who states that what we know is a drop. What we don't know is an ocean. And that is so much true when it comes to vitamin D. There are so many things which you will know today and for which we have really a multi-speciality people who have come across from various places from the country. And we have got the cardiologist, we have a nephrologist, we have a pediatrician, we have an endocrinologist, we have the gynecologist and obstetrician, and with all this disciplinary, it is the physicians and the family physicians who plays a pivotal role. And we are going to see that how vitamin D and its relation in osteoporosis, which is of relevance. So when we were just thinking about that, what are we going to talk about and the relations, what we have with osteoporosis? We know that osteoporosis, which is one of the silent disease, which people don't even appreciate. And if you look at the statistics, the alarming figures, above the age of 50 years, 1 out of 3 lady and 1 out of 5 male suffers a osteoporotic fracture. And the impact, it is not only to the patient, to the family, the financial burden, and it's a huge one. And where something can be done, you know, people usually take it post-menopausal women. Now people have got the concept that they have to take calcium. But is calcium adequate enough? So there are so many ifs and buts, and which we are going to address from different specialities also. And to begin this, you know, first, I would like to introduce our chief guest for the program and the one who has given the boost for today's program, none other than we have got Professor Dr. D. Nageshwar Reddy with us. We welcome, sir. I would like to give a formal introduction to the sir. One sec, I will. Can I move the slide? This is stuck. Okay. So this is what happens if, you know, you may feel you are taking calcium and everything is adequate, but if the vitamin D is inadequate, you may be stuck. And this is what technicality, the hitches which can come up. So that is where the role is. what is most important is you need to have the conglomeration of the best of the team. Okay, so it's my honor and privilege to welcome Professor Dr. D. Nageshwar Reddy, the Chairman and Managing Director of AIG Hospital. Who doesn't know, sir? He has left a benchmark in the field of not only just gastroenterology, but in the teaching institute across the country. Sir is a renowned gastroenterologist, studied at Kurnool Medical College. He is right now the chairman and the founder of Asian Institute of Gastroenterology at Hyderabad, the biggest gastroenterology center in the world. And it is really a matter of pride for all of us. He received Padma Sree Award in 2002 and Padma Bhushan in 2016. And all you know, by next Vitamin D Conclave, we might have to say Padma Vibhushan also. So, sir, we look forward for that. He is elected fellow of the National Academy of Medical Sciences. He was given the world's highest gastroenterology award in Shanghai, which was a function which was held in September 2030. He was conferred with Rudolf Schindler Award, the highest category in the prestigious Crystal Awards, named after Schindler, who is considered as the father of gastroscopy by American Society of GI Endoscopy. If we go on reading his biodata, we would have to have one session full on that. So without much wasting time, I would request, sir, please come over and address the gathering. We can start with the formal function, sir. Thank you so much.
Thank you, Dr. Ketan Mehta, for this kind introduction. On behalf of AIG and Pulse, I'd like to welcome you all to this very important meeting. In fact, often vitamin D is a neglected subject, and I think it's an important occasion, the World Osteoporosis Day, that we're having it. A couple of small notifications that I have on this. First is regarding Mr. Rambabu. I know it's a vitamin D, but it's very tempting to talk about Mr. Rambabu because Rambabu and me, we started practice almost together. When he started this small pharmaceutical company, I used to be in a small place called Medinova, and he would come often, very often late in the night, and our careers actually parallel together. The thing about Rambabu is he hasn't changed since then. He's a very unusual CEO. He's very shy. He doesn't want to talk. He doesn't want to come to the front. But behind, he's such a powerful force that has motivated this team. And Pulse has become a very strong pharmaceutical company. People don't realize it. And even now, if you talk to him, he's very shy. He's not the typical pharmaceutical CEO that we see. So I think it's been a great pleasure to know him for so many years. And I think he has done a lot for developing many unusual type of substances like vitamin D. Now, vitamin D, unfortunately, got associated with osteoporosis, osteomalacia, things like that, with calcium. Actually, vitamin D is not a vitamin, it's a hormone. If you look at the structure of vitamin D, it resembles all the hormones. And like a hormone, it has got a huge varied functionality. The functions are so many. And for a layperson, osteoporosis, by calcium, vitamin D, those associations. But what we don't realize is vitamin D practically plays a role like a hormone in every part of the body. In gastrointestinal tract, for example, we have a lot of evidence that vitamin D is a cancer preventive agent. Vitamin D also is responsible for actually immunity in the GI tract that we see. In fact, there's some studies that have shown that the reason why Indians who are supposed to be have deficiency of vitamin D didn't develop during problems during COVID was because of, I think every prescription had a vitamin D in COVID patients. And that was very good because it actually boosted the immunity of these people. Whereas Western countries, for example, in US, very hardly was vitamin D prescribed in COVID patients because they thought vitamin D was sufficient or not important. But we, for some reason, this came in, and I think a lot of our COVID mortality and morbidity was related to a decrease, prescription of vitamin D. So vitamin D, I think, is a very fascinating compound. In fact, about 10 years back, we had in this very hall a symposium on vitamin D covering the whole day. And as we grow now, the literature seems to be growing. And particularly about this particular compound from Pulse. In fact, many medical reps come to us and they tell me, this is the compound which is being, manufactured by the company. Just taste it, sir, it's good. So generally we refrain from tasting, busy practice, we keep it aside. So this Dexil, I think, Dexil is the one which Pulse, so they came and gave it to me and they tasted. And I was sort of trying to be polite, so I tasted it. And it was so tasty that I got addicted. In fact, now what I do is every day my dessert is 2 puffs of Dexil. So I get the vitamin D and the dessert part is served, and I think my nutrition is served well. So it's a very tempting compound that they have produced. So I think this is a great initiative by Pulse to start this, because this is not a very easy symposium to have. Fortunately, I think once the traffic clears a little, we'll have more people coming in, and I'm sure it'll be very, like Dr. Ketan Mehta said, it'll be a very important part of our education. Thank you very much.
So, thank you, sir. As you rightly said, as the traffic gets little lighter, we will have people flowing in. That's what exactly happens when vitamin D is inadequate. You don't get your calcium going to the bone, and we are going to see that. At this juncture, I would like to invite Mr. Rambabu. We have heard a lot about him. Let's say, sir, if you can just welcome the guests and the audience today and say a few words before we start the scientific proceedings, sir. Dr. Rambabu, please. I would put it Dr. Rambabu because you have already a part of it.
So thank you very much, sir. Those kind words that you said about me. Yes, I'm. I'm shy because basically because particularly you're all stalwarts. You're technically I'm not a technical person, so therefore I would not like to talk a lot of technical stuff. So that's the reason I try to be I don't try to talk much. But now about Pulse Pharma, sir, I think 97 we have started this journey. So when we started, of course, we started like any other pharmaceutical company. As we go along, so we realize that Indian pharma needs a lot of innovation. Indian pharma is known for its generic drugs. So we are known as the world's pharmacy capital, but there is hardly any innovation that happens in India because innovation is considered very expensive. So we have seen an opportunity. Innovation is not very expensive when we don't do that chemistry. The NCEs are very expensive. When you have to develop a new molecule, it costs big money. But if you identify the limitations of some of the existing drugs and try to overcome those limitations with drug delivery technologies, so it is not very expensive. That is what we try to do with our vitamin D3, sir, because vitamin D3 was not owned by any single pharma company. It was there for ages, and there's so many countries. This is available more as a supplement, but it is not available as a therapeutic product. So we have seen if this product, if there are varying standards of this product in the world. So each formulation has got different overages. So there are no standards prescribed for this product because it has not been used as a prescription product. Many countries, even in US, sir, today also the vitamin D3 is not available as a prescription product. So probably the Pulse will be the first company who is applying to US FDA as a prescription product. We are already doing some pilot studies in CKD-induced secondary parathyroidism and psoriasis. These are the 2 studies we are doing in Hyderabad now as a pilot study. So once, based on the outcome of these trials, so we want to now take it to the US FDA, file it in US FDA as 2 separate programs. So this potential we have seen. First thing what we have conquered here is we have standardized this formulation, because without standardizing that CMC, it is very difficult to have the reproducible clinical results. So each formulation behaves differently. So thanks to this nanotechnology, we have been able to standardize the product, we have been able to develop vitamin D3 with 0 overages, sir. First, probably we are the only company who could do this. Most of the vitamin D3 formulations you will find in the market with high amount of overages, up to 100 plus percent, overages. So that we have overcome by using this technology, because we have been able to stabilize the vitamin D3 by entrapping it into a carrier, nano carrier. So that is something which we have achieved. And this, our product remains stable for 3 years, sir. There is no product in the market which is stable for 3 years. Usually what we find in the market have about 18 months shelf life. So all this became possible with this technology. And we started this nanopharmaceutical technology as our approach. And vitamin D3 was the first product that we have developed. Last 10 years, we have been marketing. And India today, we are, I think, maybe the 3rd largest brand in India. And we are aiming to become the leader brand. And apart from India, we are taking this product into 40 other countries other than US and Europe. All the emerging markets, the same product is registered now. And so this vitamin D3, we want to be the real clearly leader. And we have done a lot of clinical work, also clinical development. We have done so far about 7 clinical studies, plus the 2 new studies that we are doing. So we are continuing to develop the better understanding about its clinical efficacy. And some of our investigators like Dr. Marua, Dr. Vasireddy, all of them are here. So, and most of the studies were done in Hyderabad. We have done one study in COVID also, sir, in Gandhi Hospital. So where we found very encouraging results, and this study got published in Nature Scientific. So this is something, we take pride that we could generate so much of evidence out of, a nutrient like vitamin D3. And that became possible because of our technology. And what we have seen is across all studies, we have seen the similar results, that the rise in D3 was consistent across all studies. And we have seen almost like 8 to 10 nanograms per each 60,000 IU 5 ml bottle. So that is something which we have been able to achieve because of our formulation standardization. So whereas with a lot of other studies which we see in the in the academic studies, there are varying results. So those varying results is something that we could control with our technology. Now, after vitamin D3, we are now working on vitamin B12, and we are working on iron. We are also working on certain other pain medications, like simple medications like paracetamol. So we have developed a product for the first time, a complete clear syrup. Actually, it is not suspension. It is not a solid dosage form. So we are now planning to bring this product into the market, both for pediatric as well as adult use, because today paracetamol is very commonly used. There is no drug, for fever and pain after paracetamol. But there are a lot of limitations with the paracetamol, because paracetamol also, like vitamin D3, is found to have varying, bioavailability because of the formulation challenges. So we have overcome that formulation challenges by using a Lyomatrix technology. Then we are also working on some other serious drugs now. With all the, all these we could do with, because of the support from medical fraternity. We have been there for the last 27 years, and we have been encouraged to do this work. And so we are spending almost about 8% of our sales revenues into R&D. So I think companies of our size spending that kind of money in R&D is not very usual. Usually the big companies have got deep pockets to do it, because it's the passion which is driving us. So that is what our caption says: passion for innovation, compassion for people, because we identify the unmet needs in the existing medicines, and then we try to overcome that with a incremental development. And therefore, and these are we position them as not very expensive alternatives. These are affordable premium is what we try to develop these products. So we don't want to make it too expensive by spending too much money on R&D. So our average time spent on our product development is about 4 to 5 years. In fact, our first product we started in 2010, 2014 is when we could commercialize this product. So now we have about another 8, 9 products in the pipeline, so which we are planning to bring out, and we have filed global patents. And so Pulse, I think in the times to come, will be more known for novel drug delivery technologies and more known for nanopharmaceutical, because nanopharmaceutical technology is something that we have perfected. We have the team now which I think very few companies have got that kind of team. So that is what is considered as our strength. And we have understood the actual science of nanopharmaceutical technology, because there are only about 20 products which are so far approved in USR, which are considered as nanopharmaceutical products. And most of them are injectable products. There are hardly any product which is oral product. So we have been working more on oral products because oral products are most used and they can be commonly used by more people. So that is what is the approach that we have taken. So far, mostly the nanopharmaceutical products are like oncology. We have paclitaxel, then doxorubicin. So we have even our iron sucrose is a nano product, sir, actually. So that's also, Wife's product is a nano product. So there are about 20 products so far which are approved in US. But that means which is very difficult to develop these kind of products. If it would have been so easy, there would have been more companies who would have ventured into this space. It is difficult technology. It is complex technology. So unless you understand the science deep, it is difficult to standardize and, achieve that, the CMC standards. So that is something we have been able to do it. And today we can, we take pride in our strength. And we are also collaborating with companies like Abbott, Sanofi. Even globally, we are trying to partner with some large companies like RB, Rickett, Kaiser, and all those kind of companies. So for us to take these products into more markets. So thank you very much, sir. Thank you.
Thank you, sir. We could really feel the passion for innovation and research, which was just speaking out like the way it was flowing, sir. So we admire that. And we wish, of course, the Pulse will go a long way in getting the newer and newer molecules, which will be of benefit to all of us. Now, may I invite the main mastermind behind. No, don't get just carried away. Once the word comes mastermind, you always start worried about, mastermind behind the blast and all this. The mastermind behind today's program, my dear friend, Executive President from Pulse Pharma, Mr. Samar Ghosh, to say few words and then can just felicitate today's chief guest and guest of honor. Samar. Okay, so now we'll start with the scientific program, and I would like to introduce the faculties and the panelists for today's program. As I told you, we have multidisciplinary faculties with us. Of course, as we were little late and our first speaker had to go early because had some medical emergency. So we will be missing it. But of course, he has conveyed his blessings. Professor Dr. B. Somaraju, eminent cardiologist from the Care Hospital, Hyderabad. We have Major General Dr. R.K. Marwa, consultant endocrinologist and scientific advisor, International Life Sciences Institute, India. May I invite our chief guest and guest of honor, to be over here and just felicitate all our faculties, sir. We would appreciate. So, Dr. Marwa, sir. Marwa, sir has been the postgraduate has got a certificate course in hospital administration besides his uh, professional qualification of endocrinologist. He is the former additional director and head of Department of Endocrinology at NMAS Ministry of Defense, New Delhi. He has got a fellowship from Commonwealth. He has a WHO fellowship and a past president of Indian Society for Bone and Mineral Research. We welcome you, sir. Our next faculty is Dr. Vijay Kakatkar. Sir, please welcome Chief of Unit and Director of Ramakrishna Medical Research Center, a renowned senior orthopedic surgeon, trauma and spine specialist, has been a member of various organizations, has been a president of Ramakrishna Medical Research. He has been a postgraduate teacher and immediate past president of Maharashtra State Orthopedic Association. We welcome you, sir. May I invite Dr. Rajesh Racha, again, a senior orthopedic consultant from AIG Hospital, a senior trauma surgeon, membership of various organizations, publications in various index, national as well as international journals, and special interest in arthroplasty. We welcome you, sir. Our next faculty is Dr. Manjula Anagani. She is a consultant gynecologist, laparoscopic and robotic surgeon, urogynecologist. She is the clinical director and HOD at Care Vatsalya Women and Child Institute. She has a Guinness record holder for the highest number of fibroids removed from a single patient. We welcome you, madam. Our next faculty is Dr. Sree Bhushan Raju, nephrologist, senior professor, unit head at NIMS, Hyderabad, gold medalist in DNB nephrology, has more than 3,300 lectures in scientific forums and more than 1,000 public talks, has been reviewer for many journals, and we welcome you, sir, for today's program. Our next faculty is Dr. Sri Krishna RSV, a senior consultant pediatrician at Apollo Clinics, associate professor at Dr. VRK Women's Medical College. He's been associated with various organizations. He is an executive board member of PEDA TS. He is a project director of Newborn Quality Improvement Project and has got various awards. Welcome you, sir. And last but not the least, the faculty is Dr. Vasireddy Nayana Tara. She is a consultant endocrinologist at AIG. She is involved in the research work in the field of medicine, focusing predominantly on medical disorders in pregnancy, and has got various papers presented at national and another conferences also. We welcome you, madam. So with these words, we would start with the scientific programs. There are certain things I would like to tell to each and every speaker, because we are running late. So your time allotted would be 10 minutes. So after 10 minutes, there will be a villain which will appear and would give you a beeper so that you will stop at 10 minutes. So would request, we would have to constrain to that. Our first talk, which is now we would be taking, is vitamin D, most studied, much elusive still. A recent update from Dr. R.K. Marwa. Over to you, Dr. Marwa, sir.
Thank you, Pulse Pharma, for immense pleasure to welcome our moderator and one person we know who makes entire panel discussion as an interesting factor. I request Ketan sir to please be on the dais and request MD sir as well as DN Reddy sir to please join in.
Thank you, Chairperson, for those kind words, and thank you, Pulse Pharma, for having me here today. I was told to speak for 15 minutes. I'll try and make it to, whatever little time I have. So I'm going to talk to you primarily first on basics of vitamin D. Unless you don't understand the basics of vitamin D, it's pointless listening to the various specialists. So you all understand that vitamin D is formed after exposure to UVB rays of wavelength 290 to 300 nanometer. When they hit your skin, the dehydrocholesterol in the skin gets made to pre-vitamin D, and then due to heat, it gets converted to D3. From where to the blood, it goes to the liver, where it gets converted to 25-hydroxy-D, and then on to the kidney, where it gets converted to active vitamin D, that is 125-hydroxy-D, which then acts on a classical pathway of absorption of calcium and giving it in the bones. The non-classical pathway, which you will be listening to all these people, is that all cells in the body have vitamin D receptors, and that's how vitamin D is known to act on extraskeletal systems. So first is D3. This is the vitamin D that you would normally prescribe, which is from the animal source. The half-life of this is D30 hours. That means it disappears from your body in 10 days' time. The second is ergocalciferol, which is vegetarian source, and it is formed after exposing mushrooms and fungi to UVB rays, like you expose your skin to UVB rays, that forms your ergocalciferol, that is D2. Then is 25-hydroxy-D calcidiol, which has got a very large half-life. That's the reason why we measure 25-hydroxy-D and not D3 or D2, because of 2 to 3 weeks of half-life remains in your blood for about 3 months. And then is the calcitriol, which is active vitamin D with half-life of only 4 to 6 hours. That means you have to replace a supplement every day. But the only caution here is that because of short life, you have to give every day, but if you give in excess, it may cause hypercalcemia. So you have to be very careful. You do not prescribe, I repeat, you do not prescribe active vitamin D unless you have a chronic renal disease, renal failure on dialysis, or hypoparathyroidism, or resistant vitamin D rickets. Most of the practitioners do practice giving supplementation of active vitamin D. And you all know D3 is more potent than D2 and also have a longer duration of action. So the role of vitamin D, you all know it maintains blood calcium level, which is important for nervous, bone, and achieving peak bone density. But more importantly, it's a very potent immune system modulator, prevents development of autoimmune disorders and respiratory infections. It also controls your cell growth, controls uncontrolled proliferation, and stimulates differentiation, thereby preventing common cancers and skin disorders. It also plays an important role in insulin secretion and increasing insulin sensitivity. This slide, one slide itself will show you everything. Higher the levels of vitamin D, lesser is the incidence of all these extraskeletal disorders, whether it is cancer, fractures, osteoporosis, heart attacks, type 1 diabetes. So the idea is to tell you, for extraskeletal benefits, please have serum 25-hydroxy levels higher to the tune of 40 to 60. So what are the normal circulating levels? When we started work, there used to be LIPS classification, which used to say if it is less than 5 nanograms, it is severe, 5 to 10 is moderate, 10 to 20 is mild. Then came American Endocrine Society, which said less than 20 is deficiency, 20 to 30 is insufficiency, and more than 30 is sufficiency. But now Institute of Medicine, which is accepted all over the world, says less than 12 nanogram per ml is deficiency, 12 to 20 is insufficiency, and more than 20 is sufficiency. We get two types of unit. One is in nanogram per ml, and the other is nanomoles per liter. So 1 nanogram is equal to 2.5 nanomoles per liter. So 20 nanograms will be almost like 50 nanomoles per liter. So what are the recommendations for daily vitamin intake? What is RDA? Recommended daily intake for infants less than 400 IU per day, children adults 600, elderly 800 to 1000. And when you have deficiency, what we recommend is you give 60,000 per week for 8 weeks, followed by 60,000 once a month. But now of late, most studies have shown that daily intake of vitamin D is far superior than monthly or fortnightly. But what are the safe upper limits of taking vitamin D? For infants, 1,000 to 1,500, children 1 to 8 years, 5 to 3,000 IU per day, and children above 8 years and adults 4,000. So you should not give more than 4,000 IU. That is what has been recommended. But it has been very clearly shown that more than 10,000 taken for years together has not caused any hypercalcemia. But Institute of Medicine has laid down 4,000 as the upper limit for the clinicians to practice. This 30 nanogram, which is formed by the American Society, was based on the parathyroid hormone, which is we showed that this was least when it reached a cutoff of 32 nanograms. Calcium absorption was maximum, and bone mineral density also was maximum, as shown by these three people. So various commercial preparations, I'm not going to, you all know that, but the latest is the nano or the micellized forms of D3, which has come in liquid form, spray form, or now tablet form. What is important was mentioned by Mr. Ram Babu was that there is disparity in the commercial preparation. We did this study in 2013 when there were only 14 preparations available. And we saw that out of those 14 samples, only 4 preparations had accepted vitamin D content except in the acceptable range. 5 preparations had very high and 5 had very low. So the percentage variation was ranging from -91 to 65. And therefore, we concluded that this disparity may lead to either under or over treatment. And it's important for drug controller to have a look at this and take some necessary action. But it's not vitamin D. Please remember, calcium is very, very important. And together, in fact, calcium and vitamin D are both very important. If you take lesser intake of calcium through diet or lesser intake of vitamin D, or if the synthesis is low when you don't expose yourself to sun, there is less of calcium absorption, leads to decreased plasma calcium, increases secondary PTH hormone, that is secondary hyperparathyroidism, leads to increased bone turnover and resorption and bone loss. And in postmenopausal, when then is estrogen deficiency is there, it leads to again increased bone turnover and resorption. So various preparations, you can give any of them sub chalk hai, but the only thing is calcium carbonate, the elemental calcium is much higher in calcium carbonate. And mostly people prescribe either this or calcium citrate. And you should know what is the daily intake, what is your daily requirement of calcium, like we told you for vitamin D. And this is ICMR recent recommendation, 600 milligram, 1 to 9 years, 10 to 17, 800 milligrams, 19 to 50,000, and older age group 1,000, or in women 1,200, and in pregnancy again 1,000. So you must keep in mind, you must know how to calculate calcium intake through diet, which is very, very simple, which we can talk later. But if you are taking 500, then you have to supplement an additional 500. Now, calcium carbonate is the least expensive, has high percentage of elemental calcium, but causes constipation and bloating in some and must be taken with meals. Whereas calcium citrate, though being expensive, but its absorption is not dependent on the gastric acid. And so you don't have those GIT effects. So those who have, you can give them calcium carbonate. Is there calcium and vitamin D deficiency? Is it a major public health issue? Well, these studies by Harinarayan and Bhatia et al. Have very clearly shown that calcium intake is low in children and adults in India. This is because predominantly we are vegetarians based on cereal and legumes, and we are deficient, diet is deficient in milk and milk products. And further to that, this low content of calcium is further compromised by high level of phytates in our vegetable diet. So the important clinical points to remember is that the normal calcium intake in India is only 200 to 600 milligrams. And that is the reason why I want Indians to have more vitamin D levels. 50% of Indian population has deficient intake calcium. Absorption is 20 to 60% depending on intake. 80% is absorbed from calcium, which is vitamin D dependent. Only 20% has passive diffusion, and up to 200 milligrams is excreted. If more than 200 grams is excreted, you think of hypercalciuria. We first thought of that. This is the first paper that we published to show that high prevalence of clinical deficiency, genovirum and genovirum, almost 11% of normal children, 84 to 90% had low vitamin D, and the baseline was less than 12. Then Indian women, pregnant women, we had 540 women, evaluated them in different trimesters. You see the mean level, only 9. Vitamin D deficiency in all the 3 trimesters was between 96 to 87% when we took 20 as the cutoff, not 12 as the cutoff. In breastfed infants and lactating mothers, again, similarly, we showed high prevalence, low mean values. Neonates and infants, clinical evidence in 3.9%, and 80 to 90% were also having vitamin D deficiency. And infants born to mothers with less than 10 had 4 times higher chances of developing vitamin D. In adults, studies from Delhi, our study, Lucknow, Kashmir, and many other states have all shown. This is one where health professionals were investigated in different parts of the country. You see the circle, the red portion indicates the vitamin D deficiency. So you can imagine the status. So all epidemiological studies across the country reveal that it's a major public health problem. Does high dose of vitamin D have a role in extraskeletal system? Just 2-3 slides. Why do we say it acts on extraskeletal system? This is because vitamin D receptors and this 125 hydroxylase enzymes, which produces active vitamin D, are widely expressed in all the tissues, which are not involved with calcium and phosphate transport. 3% of your human genome are under direct or indirect control of 125. Many diseases and illnesses are associated with poor vitamin D. So that is the reason why we think it has an effect. Whether poor vitamin D status plays a causal role in disease is debatable. If the link is causal, what is the threshold of vitamin D that will decrease the risk of diseases? So these are 2 debatable points that we need to address. So just to tell you that this is a paper just to show you where Professor Michael Hollick gave vitamin D3 400 IU per day, 4,000, 10,000 for 6 months, and in vitamin D deficient patients. And if you see in 400, 86 genes were upregulated and 76 were downregulated. If with 4,000, 188 and 132 were downregulated, and with 10,000, 800 genes were upregulated and 489 were downregulated. This is higher the levels achieved, more will be the genes which will be upregulated. So the study finally showed that 25-hydroxy-D levels of approximately this high levels had showed an increase in genomic expression of genes involved in cell proliferation, differentiation, and immunity by 4-fold compared to a level of 40.8 nanograms. We've done recently 2 studies, the last 2 slides. The recent studies we just published now, this year, we gave 25-hydroxy instead of D3 because we wanted immediate rise of 25-D3 because we were trying to see the impact of vitamin D on improving the efficacy of COVID vaccine. This was done with PGI Chandigarh in association. And what did we had about 580 vitamin D deficient patients who were given 50 microgram of calcifediol, that is 25-hydroxy, for 6 months and compared with placebo. So what we found was when we followed them, the percentage of clinical COVID disease was significantly lower in those who got this supplement of calcifediol. The lymphocytic proliferation, which is involved with immunity, was significantly higher in compared to placebo. And inflammatory cytokines like IL-6 was significantly lower, whereas anti-inflammatory cytokines like IL-10 and tumor growth factors were significantly lower at 4 to 6 months of supplementation as compared to control group. And what we saw after 3 months, 1,064 genes were upregulated, 661 were downregulated as compared to baseline. And at 6 months, the total number of genes which were either upregulated or differentially regulated or downregulated were 10,000 genes who were differentially regulated, in which 6,389 genes were upregulated and so many downregulated. But the common genes which were upregulated or downregulated, both at 3 months and 6 months, 649 and 270, they were differentially expressed with calciferol. So we concluded that study presented a very novel and safe approach to improve efficacy of COVID vaccine and vitamin D through calcium supplementation. And we did show, I am not going into details, just to show you that it has this. And this is a case of congenital ichthyosis. Can you see the scaling? And inflammation of the eye, edema of the eye. Within 6 weeks of giving 60,000 IU every day, you see the anti-inflammatory effect, eyes have become normal, scaling is gone, that anti-proliferative action will be clearly seen. This is again, look at the fish-like scales, how they improve after giving high dose of vitamin D. And this is again, so we published this paper, which is now accepted, and people are practicing high dose therapy for congenital ichthyosis. This is again psoriasis, which now there is a publication for 5 cases from Pune. See, this case was given 35,000 every day for 6 months. So after 6 months, you see the scaling completely disappeared. The only thing you have to be careful is don't give calcium during those days when you're giving very high dose to prevent chances of, hypercalcemia, but maintain normal calcium and see that the PTH levels are low. Thank you very much.
Thank you. Thank you so much, sir. Sorry, you have to rush up, but you already started ball rolling. And what you mentioned was not only the skeletal effects, but the extraskeletal effects which you have started up. And we are going to have a lot of questions which will be covering up during the panel discussion. Okay, we will move on to the now next aspect, and that is, as we are celebrating osteoporosis, the first next talk would be early signs of osteoporosis and clinical management with vitamin D. And may I invite Dr. Vijay Kakatkar to talk on the subject. Sir has already been introduced, a senior orthopedic surgeon. Over to you, sir. Your time starts now.
Good evening. I think with the way the topic was introduced by Professor Marwa, I think my job has become quite simple. Osteoporosis, by definition, is a systemic skeletal disease characterized by low bone mass and microarchitectural deterioration of bone tissue with a consequent increase in bone fragility. The disease often does not become clinically apparent until a fracture occurs, so it is called as a silent killer. If we see the prevalence, world over it is 18.3 with a female preponderance, and in India it is a little higher, 24.7, again with a female preponderance. Prevalence of osteoporosis in postmenopausal women is about 35 to 50%, and the mortality associated with the hip fractures is about 20%, so quite alarming. It is often undiagnosed or underdiagnosed in the primary care settings, basically because of 2/3 of the population of the postmenopausal women staying in the rural areas where the diagnostic facilities are very, very limited. These are the changes in the bone density with the age. You achieve the peak bone mass at 25, and then after the age of 40, there is a decline which is age-related, and in females more related to the menopause. If we see the biomechanics of spine, the 80% of the impact of the body load is taken by the disc and the vertebral bodies, and 20% by the facet joints, which are the posterior structures. The osteoporosis weakens the bones by reducing the density, altering the architecture, slowing the repair, and causing faster damage, leading to degeneration. The vertebrae are the most commonly fractured bones in osteoporosis and typically causes wedging of the vertebrae with the anterior border collapsing. And the next vertebra to the collapsed vertebra has got a 5-fold more risk than a normal vertebra, which leads to a vertebral fracture cascade. And these multiple fractures give rise to a progressive kyphosis with sagittal imbalance and postural disfigurement and early degeneration. The pain arises from the degenerative changes in the body, intervertebral disc and the facet joints. There are some interesting facts that the pain is aggravated by activity, but does not completely relieve by rest. And the reason is, as the bones become porotic, and when the trabecular number reduces, that gap is filled up by the blood pools, and the intraosseous pressure of the blood, venous blood, increases from 28 millimeters of mercury to 40 millimeters of mercury in the vertebral bodies. And this leads to dull, nagging, constant boring pain even at rest in osteoporosis. The wedging is one of the types of the vertebral compression that you see, but you can see the codfish vertebrae, which is quite commonly seen in even young individuals, mainly ladies, or sometimes you get a concertina collapse or a total collapse of the body. But the pain may not be localized to the area of the vertebral collapse because of the widespread muscle spasm. For the bone health, you need balanced diet, regular exercise, adequate calcium and phosphorus intake, and vitamin D. As it has been already said, it is a hormone which is synthesized in the body with the presence of UV rays, and it has got an important role in the calcium homeostasis and bone metabolism, which has been already explained. The deficiency in young people causes osteomalacia, and a subclinical deficiency is extremely common and widely prevalent in the society. The other roles have already been explained by Dr. Marwa. Analgesic, anti-inflammatory, and immune system is the one which is involved. And these are some of the papers which support this particular role of vitamin D. This is a typical picture of osteomalacia in young females that you see. This is the loser zone, which is seen in the neck of the femur with coxa vara and in the proximal femur. Another lady having loser zones in the proximal femur. They come with waddling gait and typical pain. It was thought that because of availability of sunlight almost throughout the year in India, the vitamin deficiency is not very common. But we now find exactly opposite, that in the urban as well as rural population who are working in the fields, we find a lot of vitamin D deficiency. I think it's a point which we will definitely like to discuss amongst the faculty. Vitamin D deficiency, as it has been already explained, leads to chronic hypocalcemia, hyperparathyroidism, and that increases the risk of osteoporosis. I think these mechanisms have been already explained by Dr. Marwa. This increase in the PTH leads to increased bone loss, which leads to osteoporosis. And I think this cycle also has been shown of remodeling by Professor Marwa, so it makes my job easy. Vitamin D deficiency is widely prevalent among all the age groups in Indian population. And there are a couple of studies wherein we have found that the vitamin D deficiency was seen in the insufficiency fractures to the extent of almost 74%, and out of which 40% of them had hyperparathyroidism. And amongst the hip fracture group, again, almost 75% of them, they had vitamin D deficiency, and 2/3 of them had hyperparathyroidism. This is a bar diagram which shows this particular relation of vitamin D deficiency with hyperparathyroidism. These are some typical cases wherein you see this widening of the disc space in young ladies, where there is a correlation. The vitamin D levels were just 6.2. This is another lady who was just 34 years, and you can see that the vitamin D levels are just 15. And you can see this widening, and they come with persistent back pain. As far as the spine degeneration is concerned, I think there are a couple of factors involved. The vitamin D deficiency leads to proximal muscle weakness, in addition to the osteoporosis, which we have discussed. And this particular muscle weakness, along with osteoporosis, leads to loss of balance and frequent injuries, which adds to the degenerative process. This leads to spondylosis, which leads to degeneration in the disc as well as in the facets and leads to chronic back pain. The vitamin D supplementation in osteoporosis in a meta-analysis showed that the incidence of falls and fractures in a large population of 58,000 people, there was a definite benefit in preventing the incidence of fall in these patients. As far as the BMD and the relation of vitamin D is concerned, there are enough number of studies which show that if the vitamin D is given in adequate doses, there is an improvement in the BMD pattern. These are a couple of studies which show that after giving vitamin D in the dose of from 500 to almost 1200 units every day, there has been an increase from 2% to almost 7% in the BMD. As far as prevention of the fractures in osteoporosis is concerned, because of the intake of vitamin D, the bone strength increases. Along with that, the muscle strength increases. So the susceptibility to falls is also reduced. And that definitely gives improvement in the pattern of the osteoporotic fractures. I think Dr. Marva has already discussed in detail about the adequacy of the vitamin D doses. And it has been found that giving calcium and vitamin D improves the serum calcium and vitamin D levels and the activity level of the person. And it reduces the pain, the weight, and the BMI. I think Dr. Marva has already given idea about the administration of vitamin D on daily doses and weekly doses and high dose of vitamin D on everyday basis. And it has been found that this high dose has been definitely very useful. To summarize, the osteoporosis is called as a silent disease since bone loss occurs without any specific symptoms until there is a fracture. Osteoporosis and fracture can have a profound impact on physical function and everyday activity. This leads to acceleration of degeneration process in the skeletal system, including the spine. So supplementation of vitamin D, preferably in nano-carrier form in short-term high doses, has definite benefit in patients with vitamin D deficiency with osteoporosis or fragility fractures. I thank you very much for your attention. Thank you.
Thank you, sir. You just finished right on time. Appreciate it, sir. We'll move on to our next orthopedic surgeon, Dr. Rajesh Racha, who would be speaking on the link between trauma, bone health, and vitamin D. So from osteoporosis, now we are moving ahead, and I'm sure, because this is also a very important aspect. And how does now this is going to play a role? Over to you, Dr. Rajesh.
Yeah, thank you, Dr. Ketan. Good evening, everyone. And thanks, Pulse, for this opportunity. So the common topic being vitamin D today, there will be overlap of concepts and the thoughts. Today I'll be talking about the relation of vitamin D to trauma, bone health, and the fractures especially. So we'll try to address these questions. So what does vitamin D to the bone health, which we all know and has been already alluded to? Does vitamin D supplementation help in preventing fractures at all, especially in elderly in osteoporosis? And what's the role of vitamin D in fracture healing? Does vitamin D supplementation at the time of fracture will help in fracture healing and prevent non-union? So coming to vitamin D and bone health, yes, it's quite evident, and there is no doubt about it that it helps in calcium absorption and bone mineralization, which the deficiency of which causes osteomalacia in adults and rickets in children. How about in preventing fractures, though? So there is in early 2000, there's these two landmark papers by Bischoff Ferrari. It's two papers which have come in looking into the prevention of falls prevention and fracture prevention by usage of vitamin D. They did a meta-analysis and randomized trials. And
it has been proven that the treatment of vitamin D deficiency is very effective in severe osteomalacia. And it has also been suggested that vitamin D supplementation in doses of at least 800 to 1,000 international units daily are required to decrease the incidence of both falls and fractures in older women. Coming to whether these vitamin D supplementation helps in preventing fractures, further research has been evolved, and the landmark paper by DPART group, which looked into 7 major vitamin D fracture trials in the US and Europe, including 68,500 patients, and also Cochrane database, and also randomized control trial, which came up in the New England Journal of Medicine recently. So what did all these literature say? There is no obvious evidence that vitamin D alone will prevent fractures. However, with co-prescription of calcium, hip fracture risk is reduced, as also the total fractures and non-vertebral fractures. And coming to vitamin D and fractures. So what is the role of vitamin D in fractures, and how does it help in healing of these fractures? So coming to the prevalence of vitamin D deficiency in orthopedic trauma patients. So the various studies have been done, especially when looking into Indian scenario. The patients presenting to trauma with these fractures, there is almost up to 80% to 90% of these patients are hypovitaminosis of vitamin D, so vitamin D deficient, especially in patients who have multiple fractures. The number of cases with vitamin D deficiency are quite high. Once again, from a paper from Velo, did show there is a prevalence of vitamin D deficiency of almost up to 95%, which is obviously very high. And so there is no need, in fact, in Indian population to routinely evaluate vitamin D in trauma patients. So we might as well start on vitamin D supplementation in these individuals who are presenting with these fractures. So is there any role of vitamin D in fracture healing? Yes, the fracture healing, if you look into it, there is it's a complex biological process that starts with, as soon as the fracture has occurred, and it goes through 4 stages in a normal long bones. Like it goes through an inflammatory stage, soft callus formation, hard callus formation, and the bone remodeling stage. And vitamin D has a role in all these stages. So it affects on inflammatory cells, cytokines, growth factors, osteoblasts, and osteoclasts, and on the process of mineralization throughout the fracture healing process. But will this, yes, the vitamin D helps in fracture healing. But if the supplementation at the time of fracture, does that help in healing the fractures and in preventing non-unions? So there is this landmark paper, which the future research should be based on this sort of trials. So this study is a randomized double-blinded control trial, which tried to see the effect of vitamin D3 supplementation on acute fracture healing. So this study divided, the number of patients, though, are quite few in these. There's 96 patients they have taken and divided them into 24 each into 4 groups. The one is the supplementing a higher dose, like 150,000 international units of loading dose of vitamin D3 at injury and 6 weeks, compared with the placebo. And placebo loading dose with 4,000 international units of vitamin D3 daily. Placebo loading dose with 600 international units of vitamin D3 daily, and placebo as a loading dose and continue giving placebo. So what does it showed? It showed that high doses of vitamin D3 were associated with improved clinical fracture healing relative to placebo at 3 months and within 12 months. So high doses looks like it is helping in fracture healing, though it is a clinical fracture healing. However, radiological fracture healing wasn't significant. Again, there are a few more papers. Again, this is one landmark paper came up recently, Thomas Gatt and et al. They did a systematic review of almost 14 studies have been looked into, out of which there were 7 randomized control trials and 1 prospective trial. So they looked into clinical and radiological union. 8 studies have looked into clinical and radiological union, 6 studies of functional outcome, and 3 studies looking into the effect of bone mineral density. So in these overall, I mean, there are a couple of studies which showed significant differences in clinical union. However, there was no change or observed in radiological union. in this various studies and trials, ultimately they have found that the overall findings are that the vitamin D alone does not influence fracture healing and or not the subsequent union rates or functional outcome. So it again shows that there has to be, along with vitamin D, the other supplementation with calcium is probably necessary. So on its own, the overall findings of the vitamin D alone has only little influence on fracture healing. However, there are some observational analysis and some case reports which showed that there is definitely an improvement in the fracture healing. For example, this paper, which is an observational study, doesn't have much power though. They divided 100 patients, 50 of them getting regular 800 units of international units of vitamin D versus 50 of them who weren't receiving any vitamin D were compared. Out of these 100, they did not mention what sort of fractures they were looking into. They said one single fracture, but however, when they looked into these 50 patients who had received the vitamin D, the functional score and the pain levels over time has definitely improved when compared to the ones who did not receive the vitamin D, versus again, rate of bone healing as well has been shown to have improved in the individuals who were receiving vitamin D compared to the ones who are not receiving vitamin D. However, I mean, we need to, this is not a robust study, but definitely even in our clinical practice, in observation analysis and some case studies, does show there is a effect of vitamin D in helping fracture union. So with all this literature and our understanding, what does the overall summary say when compared to when it comes to the fractures? So vitamin D along with calcium supplementation can prevent fractures, especially in osteoporotic fractures and in elderly. Hypovitaminosis D is prevalent in fracture patients. The administration of vitamin D alone at the time of diagnosis does not confirm any additional benefit. Having adequate vitamin D, however, though at the time of fracture definitely has a better healing rates when compared to the patient presenting with a lower vitamin D. High dose of vitamin D supplementation has some evidence in fracture healing. So considering the benefit of vitamin D on bone health, calcium metabolism, and improved rehabilitative potential, vitamin D administration can be considered in fracture patients. The precise benefit of vitamin D supplementation in every patient who have had skeletal injury in terms of infection control, prevention of non-union, and improved rehabilitation are very difficult to assess. As you can see, the fractures, every fracture is different in every patient. The age of the patient, the site at which it happens, like in the metaphyseal bone or in the long bone, has its own effects at the healing. And also the type of fracture, it's an open fracture, closed fracture, or is it a comminuted fracture, not non-comminuted fracture, again, plays a role in the effect of healing. So it's quite difficult to randomize these fractures, but overall, as I have already alluded to, there is a role of vitamin D along with other supplementation will help in fracture healing. Thank you very much.
Thank you. Thank you, Doctor. You finished again well in time. We appreciate it. We know that vitamin D is not just the territory of orthopedic surgeon. And when we talk about gender equality, and we have a very powerful lady with us, the gynecologist, head of department, Dr. Manjula Anagani, she would be talking on equality in menopause, time of moans and groans. May I invite Dr. Manjula, madam, please. And your time starts now. No, madam, it's not.
So we had Dr. Rajesh giving me 2 more minutes of his time. So that is something. So first thing what I wanted to tell is we are all like Sherlock Holmes. We all want something to diagnose and we want to treat. We just don't want to live in the thing of inadequacies or not knowing. But there's so much to know, so much less what we think we know. It is like a drop in the ocean. So I would like to take you all through this, like what do we know? What are the facts do we know? What do we know about menopause? What do we know about osteoporosis and menopause? And what are the facts about it? Is the pathophysiology different from what we had Dr. Marwa and everybody talking about? And can we do something to prevent it? So in that, what do we know? We know that in today's time, premature menopause is happening more and more. because of pollution, dioxins. We have 20-year-old having menopause, 18-year-old having a premature ovarian failure. And we do know Indian average is much less than the Western world. And we also know climacteric starts about 8 years before the menopause, means the actual damaging sequences are happening much before we talk about menopause itself. And immature thing is that 1/3 of our life expectancy has increased. 1/3 of our life we are going to live in menopause. So we better understand how we have to take care of our lives after that. So what do we know? The early effects we all talk about: erythral syndrome, vasomotor, my wife shouts at me, my wife is short, my kids, all these things everybody talk. But nobody talks about the moans and the groans which she's going to have because of osteoporosis and the pains which she's going to have, which is the late effects that is on the cancer, that is on CVD, the strokes, and the bone. So risks encountered, what we said is, this is the facts, what we know. Bone health, about half of the people post-menopause, 50% are going to have osteoporosis, 1 in 3 are going to have fracture. So is it different from the men? Gender equality? Yes. We always say we are lucky to have estrogen because our memory is very good. We say that we are very lucky to have estrogen because we will not have heart attack before menopause. But recently we saw a 38-year-old having a heart attack. So this is something which is changing post-COVID, or what is happening. And we do know after menopause, our bones are going to be much more fragile than the men, what is going to happen. So breast cancer, again, we have seen so much increase in breast cancer, and CVD also is the leading cause of mortality, which we are seeing. So to put it in a nutshell, 50% of women over 50 are going to have osteoporosis, and 1 in 5 men will have 50. So it is 20% versus 50% what they're going to have. So what do we know about both the things? Menopause itself is categorized as at risk for osteoporosis. So it's an extra risk factor which we have to understand. And the most common bone disorder is not fracture, not anything, but osteoporosis, which we have to understand. And the first 4 years after menopause, about 10 to 20% of the bone loss is going to happen. So the fast bone losers are more in women, that is 25% again. So if you take the National Osteoporosis Foundation, it says, compared to men and women, we have less bone density and more people who are having osteoporosis. And similarly, the fracture risk is very high in the women. And our lifetime risk of fracture in 60% is as high as 50%, which we talk. We always try to blame it on men. Yes or no? Our life becomes a living hell because men enter into a woman's life, menstruation, menopause, mental breakdown, everything. But let me put it in a nutshell. When we actually want to see that we have become sane and we want to think everything logically, the body starts giving way. At 50, we think all our responsibilities are over, then the bones will start giving way. So let us talk from menopause to menopause. So let us see about the quality of life, where we talk about there's no pause to me, that is where we come in. So pathophysiology, what I thought we'll put it is, we spoke about 4 hormones. We spoke about estrogen, we spoke about PTH, calcitonin, and vitamin D. Calcium is something which is a mineral which is needed in it. But when we put it in a nutshell, we know that estrogen, most important is the osteoblastic activity is something which only estrogen can achieve. The osteoclastic resorption, which is going to happen, is also decreased because of the estrogen effect on PTH and calcitonin. And estrogen also has an effect on the bone itself. So that is what we need to understand because the receptors are there. So at menopause, we are losing out on estrogen. So the turnover is the thing which is going to be lost. Means osteoblastic activity comes down. Osteoclastic activity is going to become worse. So the bone which was like teak wood will become like a bamboo shoot. So we know everything what they said, and that is what we are talking about. Apart from just the estrogen, we have vitamin D, which is independent of estrogen going to act. So we have deficiency of both, means dono haath se taaliyan. So that is where we are living in. So here, if you put it in a nutshell, is the marker here? Estrogen deficiency acting on the osteoblast, and estrogen deficiency acting on the osteocyte itself and also on the osteoclast. Together, putting it is a turnover which is going to be lost. I don't want to go too much into theory, and we do understand basically what's happening is the bone loss is going to be much more high. So loss of estrogen in menopause, because of its effect on the osteocyte, also
just your mic, because
also causes a downregulation of glucose receptors on osteoblast itself. So because the osteoblastic activity is something which we all talk about. We talk about building the bone and losing the bone. But estrogen effect on the glycolysis is something which is causing the reducing osteoblastic activity. And we also speak about antioxidants and ROS. So that is also affected because of estrogen. So what is the prevalence of vitamin D? We have been hearing about vitamin D everywhere, and we are talking about high dose of vitamin D. Does it actually affect? And on one side, we talk about hypervitaminosis, how dangerous it is. So estrogen reduction will definitely decrease the vitamin D receptors. And we have seen that estrogen itself increases the activity and responsible for activating vitamin D and also upregulates the receptor. So after menopause, the receptors are downregulated. So not just the estrogen deficiency, it also causes vitamin D deficiency itself. So together, again, we have double the markup. So this is where we have muscle loss, strength, osteoporosis, breast cancer increase also. So we heard Dr. Marwa talking about increased cancer risk, increased muscle loss, increased everything what can happen. So apart from the estrogen deficiency, which by itself is an additional risk factor, we have rest of the things which come with that, where we think we are tired, our age is catching up, we won't have to behave like this, so we don't active, we are not active, and we are on steroids for some reason, or so many other things which can act as a cofactor. And we, Hyderabad being the diabetic capital, we know what can happen. So we heard Dr. Kakatkar talking about the silent fractures which we are going to have. So this is where it is till the fracture happens. And as such, Indian woman or somebody who will say everything is fine till the actual things start happening. That's where the fracture starts happening, and the vertebral fracture is the most common, comes shorter. And then the pain is something they cannot move, they'll be moaning, groaning. That's when they again go to the orthopedicians for TKRs. And that's where everything lies down. Okay. You want me to be on the side only? So no problem. So it's a tenderness and the kyphosis, it's something which is going to happen. So can we prevent? We all talk about the good food. We all talk about avoiding the smoking, avoiding the alcohol, and eating calcium-rich foods, and vitamin D, how are we going to get it? And anabolic exercises. So when we talk about smoking, which is increasing today's time, whatever said and done. So we talk about the procoagulant activity of smoking. It is not just the nicotine and its effect on the reduced bone formation because of the effect on osteoblasts also, plus the effect of the nicotine on the liver will cause more estrogen loss. So we are having something which we have to worry about when we talk about this. Effects of exercise. Why did I put this slide? Because everybody at 50 now want to do marathon. They want to go hiking. They want to do everything. 50 years, they didn't have time for anything. So they want to do something like this. And they want to have a fracture. So please, we need to understand, respect the age. You want to do everything. We want you to be active, but don't be a patient of an orthopedicians का बहुत ये patient बनने की जरूरत नहीं है. So safest exercise is walking 4 to 5 times. I think that is the anabolic exercise is what we look at this time. So treatment, we all talk about pharmacological, hormonal and all. Why did I put this slide? Because it is an interdisciplinary thing. I wanted to put this slide because people have fear about hormones. They think hormones are dangerous. Patient goes to a cardiologist, stop estrogen. Patient goes to somebody else, stop estrogen. So we are still stuck in WHI, but we have a lot of hope trials and everything which say osteoporosis is the only indication where estrogen should be given to prevent the fractures. So hope study says postmenopausal females below the age of 60 who are prone to fractures within 10 years of menopause, please give estrogen. That is what is more important. And that should be the first line of treatment. And as a gynecologist, we know, anyway, we are the best. So you can send them to us. We will start the hormones. So anybody what is with uterus, progesterone, without uterus, estrogen is what we look at. So benefits of things, everybody spoke about vitamin D, high dose of it is important. But what we look at with multiple studies coming up is 40 to 50 nanogram per ml is something what basic it should be. And it should not be 20, like Sir said, we should not be looking at this. And this high doses can also decrease the breast cancer, even in the 5-year follow-up. So we are not only looking at pelvic floor, we are not only looking at PCOS, we are not only looking at breast cancer and menopause, we are looking at everything. This is actually my last slide. I have wanted to talk so much. They said only 10 minutes are enough. So now with the menopause, my Alzheimer's, my dementia, everything is going to increase if I don't take care of myself. So there's a single light of light, and to shine it anywhere is to shine it everywhere. Thank you.
Thank you, ma'am. That was at a super fast speed, super jet. You conveyed the message, and the message was conveyed to orthopedic surgeons also that their job is at risk, which you clearly conveyed it. Okay, so we accepted gender bias, which is definitely no more there. And of course, we is equality. Now we move on to the next speaker, Coming to now nephrology, Dr. Sree Raju, who would be talking on CKD and osteoporosis, monitoring vitamin D levels to prevent hypervitaminosis D. So Dr. Raju is a nephrologist, and I'm sure he would be highlighting on this different aspect also. So what even that madam has said, that what is dreaded hypervitaminosis D, is it really so dreaded? Anyway, we are going to take up in the panel. Over to you, Dr. Raju.
So good evening, everyone. The entire auditorium is still reverberating, and I need to bring you back from the aura created by Dr. Manjula Anagani, a senior to me and wonderful senior to me. She never troubled me during the ragging, but still I could see that such a same energy during that time, and here it is the same actually. And this vitamin D and related to kidney, all of you know since our biochemistry days. How the kidney and vitamin D are linked. The science of vitamin D almost 350-year-old. It's almost as old as story of Magadira. And it was discovered almost 100 years back. But still we are talking about vitamin D even now as clinicians and researchers. And vitamin D is, I consider that as the molecule of the decade. There's no other molecule has attracted the attention of the researchers and the clinicians as the publications is concerned. Almost several lakhs of publications, including our own, related to every part of the body. I could see here the gynecologists, orthopedicians, of course, the kidney I'll be reading about, and so many other specialties, physicians, endocrinologists, even dermatologists also talking about vitamin D and all. Such a huge amount of publications were done with vitamin D. And the topic given to me is probably and with vitamin D being making a therapeutic role, I'll be talking a little bit about the pathophysiology and how it is linked to the kidney. And the title looks a bit longer and larger, but my talk will be very, very small and brief. And you know that the kidney is linked with vitamin D. The vitamin D active form, the 1-alpha hydroxylase enzyme is there in the kidney, and the whatever is there to the sunshine and goes to the skin, then to the liver. It gets hydroxylated once with the 25, and at 125 hydroxylation taking place in the kidney. And the kidney is ultimately the one which produces the active form of vitamin D hormone called calcitriol or 125 dihydroxycholecalciferol. Whenever the kidney is not good, this hydroxylation would not take place, and the vitamin D, the active form vitamin D, would not get manufactured within the kidney, and leading to dysregulation of the vitamin D that involves the calcium, phosphorus, PTH, and FGF23 and whatnot. And it also, not only that, it's decreasing the bone strength, but also it increases the risk of cardiovascular mortality, and which is the most common cause of death in our patients with a chronic kidney disease. And here, this is the calcium phosphorus which are being absorbed into the intestine. And these are the molecules, CPP molecules, which are activated and which gets aggravated in the manufacturing when the kidney fails, and in the bone releases FGF23, it goes to the kidney. And the kidney, FGF23 is a phosphoturic hormone which increases the excretion of the phosphorus and decrease the reabsorption of the phosphorus through the proximal convoluted tubules of the kidney. And this is the one which I stated, 1-alpha hydroxylase activity. When in CKD, the calcitriol levels will go down, and the calcium phosphorus imbalance will take place, and leading to the secondary hyperparathyroidism, in which most of our patients will get into fractures and the frailty and the fragility of the bones, which takes place routinely in our group of people, where vitamin D acts an important hormone that should be supplemented to all of them. And simply a few words about how the hypocalcemia can induce the secretion of the parathyroid hormones through parathyroid gland, and which increases the phosphate retention and also decreases the calcium in the excretion into the urine, and also increases absorption of the calcium and phosphate through the intestines. And as for the bone is concerned, increases the efflux of the calcium phosphorus to the bones, ultimately settling down in the normalcy of the calcium level in the blood. This is what happens routinely. This is one kind of an axis called PTH and vitamin D axis. We have one more called FGF23 and the Cloto axis, where the excess vitamin D, or even active form of vitamin D, increases the calcium absorption through the intestines. And as for the bone is concerned, it increases the absorption or the manufacturing of the FGF23. This FGF23 in turn inhibits the parathyroid hormone secretion through its cofactor called Clotho and through the parathyroid gland, and also increases the calcium phosphorus excretion through the urine. And these are being inhibited by the Clotho and the cofactor with the FGF23. And with in chronic kidney disease, which itself is an inflammatory condition, which decreases the Clotho, and it has got an activity which increases the FGF levels in the blood. That is indirectly a sign of FGF resistance, and indirectly it leads to the decreased phosphaturia and increase the phosphate, leading to hyperphosphatemia, which we routinely see in patients with a chronic kidney disease. And not only that, it increases the transformation of the vascular smooth muscle cells into the osteo and chondrocytic cells. That increases vascular calcification, which we routinely see in our group of people. If you see any patient with a chronic kidney disease, the CT scan or anything, you will see the entire aorta getting calcified. Not only that, that is low calclotho and further inflammation leads to endothelial dysfunction, which ultimately leads to cardiovascular death in our group of people with a chronic kidney disease, which is the most common cause of death in our people. And physiologically, the vitamin D and FGF23 and parathyroid gland and parathyroid hormone, these three are interlinked with the inhibition, suppression, and mutual cooperation between the three. It's a physiologically, we know all the things, what happens there. As far as the pathology is concerned, the FGF23, whenever it becomes excess, it leads to vascular dysfunction with the excess atherosclerotic tendency, which we see in our group of people, and left ventricular hypertrophy again, and leading to the cardiovascular morbidity and the mortality, and the secondary hyperparathyroidism leading to the frailty and the fragility of the bones, leading to the fractures, and also the further worsening the chronic kidney disease secondary to activated inflammation, which takes place within the kidney. So FGF23 has got several cardiovascular effects also, ultimately leading to the left ventricular hypertrophy. We had few studies in our own we have done few studies related to association of the clotho and the cardiovascular abnormalities in pre-dialysis patients. And we found that the clotho and FGF23 in routine evaluation and has got a prognostic value in these patients. And the low serum clotho and high FGF23 levels were associated with a low left ventricular ejection fraction and increased prevalence of left ventricular hypertrophy and left ventricular dysfunction in patients with a chronic kidney disease, not yet on hemodialysis. So this is an important study which we have done. And not only that, this is the one which is important, and FGF23 independent associated with the bone mineralization decline in patients, especially the elderly. We are talking about the World Osteoporosis Week this week, and which is a common phenomenon of people with the CKD, not only the secondary hyperparathyroidism, also the osteoporosis. And we call the metabolic bone disease called CKD-MBD in patients with a chronic kidney disease, where there's a dysregulation of the calcium, phosphorus, PTH, FGF23 and all. High circulating FGF23 levels also discovered to be an independent risk factor for the fragility in elderly population. And furthermore, the studies discovered that is an independent association between elevated FGF23 as well as the fragility risk in patients with a chronic kidney disease and as well as the end-stage renal disease. And this is a study which I wanted to quote. And and one of the study which we have done with the FGF23 is also not only the CKD population, but very interestingly in renal transplant recipients. We checked the FGF23 in our group of people after the renal transplantation, then after renal transplantation 1 week, after 1 month, and after 3 months. And we found that there's a significant association between the FGF23 levels as well as the calcium, phosphorus, and PTH levels. And FGF23 levels increased significantly even after successful renal transplantation within 3 months, despite having a stable graft function. And also that an increasing tendency was noted in phosphorus levels with a normal range. And also FGF23 has shown a significant positive correlation with the phosphorus. We see a lot of our patients having either hypophosphatemia or hyperphosphatemia after the transplantation. And even after successful renal transplantation, these drugs, these hormones can play a role in maintaining imbalance of the bone and leading to fractures and all. So how to mitigate the risk of hypervitaminosis D also at the same time? We evaluate each and every patient with the vitamin D levels at the initial stage itself. And whenever we see the patient, we assess the risk factors for the fractures at the same time, especially if they are elderly population. Most frequent morbidity which we see in our patients with the dialysis is the risk of fractures. And we always adjust the vitamin D levels. And you know that vitamin D excess can lead to nephrotoxicity, leading to acute renal shutdown. We used to, 20 years back, we used to see a lot of patients coming to us with a acute kidney injury followed by injection with arachital and vitamin D supplementations and all, which is very, very important. When we see them hypercalcemia and hypervitaminosis D, we used to do sometimes when calcium-free dialysis also we used to do to decrease the calcium levels in that. And increasing, whenever we see hypercalcemia, we always try to give hydration, followed by the furosemide, and also avoiding a calcium-rich diet. And sometimes corticosteroids and bisphosphonates also will decrease the hypercalcemia. And we need to always rule out some other associated conditions called sarcoidosis, tuberculosis, and the lymphomas. And there's some drug interactions are also noteworthy and we should be monitoring about. So hypervitaminosis D at the same time is equally bad in patients with a chronic kidney disease. And we should not just like the supplement each and every patient. As Dr. Marwa and other people are telling, there's some kind of a limitation. I consider that around 50 and above is important. Some of the studies recently showed that the inflammatory, anti-inflammatory activity and the better immunological activity of vitamin D takes place only when it is around 50 and above that. So cutoff of 50 will be better in our patients, but we don't really try to increase the doses, and we always monitor vitamin D levels frequently whenever we see. And thank you very much for the kind attention. This is a brief summary about how the kidney and FGO23 are linked. Thank you all.
Thank you. Thank you, Dr. Raju. You mentioned about the hypervitaminosis D. Of course, there are a lot of questions which are going to be there, which we'll be discussing over there. I think those who are getting up, let me remind you that there is no break. I would just request if all of us can stand for a minute, please. I would request everyone to stand. The reason for making you stand is twofold. One is, as Madam has already said, physical inactivity can lead to osteoporosis. Let's do some activity. Just raise your hand sideways and come down. So that's you are doing some activity. So you have reduced your chance of osteoporosis by 0.01% at least. And second, this was the break. So tea break, no tea break, we go on to the next one. Okay, you may sit down, please. Thank you. So now listening all this, let's be like a small kid. This is what we do. And now may I invite our expert for the kids, our pediatrician, Dr. Sree, who will be talking on rickets and vitamin D and what is the role of compliance in vitamin D treatment. Over to you, and your time starts now.
Namaskaram everyone, and I bring greetings from the pediatrician community, and many thanks to the organizers for having me here. I know I am talking at 8:51. Some of you who are hungry, some of you who are angry, some of you who are sleepy, all of you, I request your attention just for a couple of minutes. We've had a lot of information and some of it has been exceptional perspectives on vitamin D. And I'll quickly take you through vitamin D and the child. You know, the only medicine that is given for a newborn? Vitamin D. Yes. So at discharge, a healthy newborn goes back with only one medicine, which is vitamin D. So that's how important vitamin D is to the newborn, because it's not there in adequate amount in breast milk. So vitamin D has a lot of role. And my discussion today is trying to understand the common thread between rickets and osteomalacia, and then tell you about what the pediatric perspective of vitamin D is. So I'll not delve too much into some points which are already covered. So we know that bone is a hard tissue. You require a mix of mineralization, adequate amount of calcium, phosphorus. And we also know the difference between rickets and osteomalacia. What I see most of the time is all rickets. And rickets is the term which we use when we have very specific diagnostic criteria. So the criteria is where you have rachitic changes on the X-ray. And these are very distinct. All of us remember our MBBS days where this used to come as spotters, isn't it? So these are very, very specific. No other disease will have this kind of a X-ray picture. High alkaline phosphatase, hypophosphatemia or hypocalcemia, and then the clinical signs. And then you have a terminology called possible rickets or definitive rickets. I'll not delve into osteomalacia. We've already had that discussion. And this is the essence of the entire vitamin D metabolism and etiology, beautifully elaborated by the earlier speakers. Now, what I'll come to is the classification of rickets. So we have understood the metabolism, the definition. Now that you have seen the classical clinical picture, the typical X-ray findings, and you diagnose it, now you will have to classify it. You have calcipenic and phosphopenic. Phosphopenic is the one where renal tubular disorders are the primary causes, and very rarely it will be specific dietary vitamin, specific phosphate deficiency. In most of the cases, what we see is calcipenic, wherein we have nutritional and non-nutritional. Non-nutritional is to be suspected in those inborn errors of metabolism. Again, a very rare condition. But most of the time, so once you find the typical rickets wala definition, then most of the time it is nutritional rickets. Nutritional rickets, vitamin D deficiency. This commonly happens when there is maternal or parent nutritional vitamin D deficiency. There is reduced skin synthesis due to inadequate sun exposure. We'll delve into this a lot more later. Malabsorption, drugs, and then nutrition continues to be the predominant cause of calcipenic nutritional rickets. Now, what is the pathophysiology of this subset? In calcipenia, there is a calcium deficiency. So once there is a calcium deficiency, it causes secondary rise of parathyroid. So secondary hyperparathyroidism, raised parathormone levels. Parathormone will try to normalize the calcium. Where will it pick it up from? From the gut, from the bone. So it will give rise to increasing the active vitamin D and also bone resorption. But this high amount of parathormone will cause phosphate loss. It's getting the calcium in and pushing out the phosphate. So phosphate is lost through urine. So hypophosphatemia and impaired apoptosis of the hypertrophic chondrocytes. So this mechanism will result in those X-ray features. Early stages will have normal calcium, but then you can recognize it by high parathormone, elevated alkaline phosphatase, low phosphate levels, and a combination of calcium deficiency and vitamin D deficiency often is the cause. As we discussed, vitamin D is very less in breast milk, and most of the newborns who are now transitioning after 6 months of exclusive breastfeeding, we'll have to counsel them on the correct diet. Now, the stepwise approach to diagnosing and managing rickets. The first one is to look at what are the clinical features of rickets. Next, any symptom or sign of non-nutritional or a systemic disease. Is it looking like IEM or other genetic disorders? Next, look at workup for non-nutritional rickets. Continue to look for X-ray, blood markers, workup as per the underlying symptom cause, blood gas, urinary excretion studies, renal ultrasound for nephrocalcinosis. Suppose there is no sign of a non-nutritional rickets or no sign of a systemic disorder. Then we do the baseline wrist X-ray, blood markers, and then prefer a daily vitamin D therapy with calcium. And then you assess the response to therapy at 12 weeks by looking for radiological healing, improvement in blood parameters. And then we also check for hypercalciuria for vitamin D toxicity if the child has received multiple doses of vitamin D. If there is a good response, then we give dietary counseling for calcium and vitamin D intake, and that is how we solve it. So we know why it happens. We know how to classify it. We know how to treat it. Now let me come to why are we discussing all this in the vitamin D conclave and why are we bringing it up here? The reason is that the vitamin D dilemma, wherein they started to understand if all the simple nuances of vitamin D are actually known to all the pediatricians, all the health workers and the doctors. And as per studies assessing the KAP of physicians, pediatricians on nutritional vitamin D deficiency, they realized, I'll just cut short on this. The summary is that the study identified that there are lots of gaps, and these are knowledge gaps. Please understand, this is not the child's fault. There are many disorders where you eat bad and then you pick up typhoid, you pick up obesity, a lot of things where the person is to be blamed. This deficiency is not the child's fault at all. And it is the physician's fault where we were not able to identify it in time, not able to give a simple medicine that could have avoided this, not able to counsel mothers effectively to handle their newborn's health. So there are a lot of gaps. And these gaps, again, the adherence range in terms of treatment also range between 14 to 95%, wherein we were just writing the medicine and not counseling well enough. And the compliance to the prescription of a routine vitamin D supplementation is also very poor. Reason being, we haven't spoken enough, counseled well enough, or made the parents understand the importance of vitamin D. So only 29, that is 8%, were receiving appropriate routine vitamin D supplementation in terms of the dose, frequency, and also the duration. So something as simple as vitamin D supplementation is also not being implemented. So how do we now solve this challenge? One, by better knowledge. All of us have to take it upon ourselves that vitamin D is a hormone. It is a life changer. It post-COVID, we have realized the importance of immunity. All of us, even our own relatives, keep asking us, how do we boost our immunity? As parents, many of you who have your children, the first thing you want to know is, my child, now we're just getting into winter. You don't want your child to get the seasonal cold, flu. How? By improving their immunity. This word called immunity suddenly just crops up. And we all want this good immunity for our children. Trust me, broadly speaking, there's no magic pill for it. If you look at your own self, your own.
There is AV is missing.
No, that's it. I'm done there. That's the last slide.
Oh,
that's all.
Okay.
So just last couple of points. So your own immunity is defined by one, your sleep, most important, by the nutrition, the intake, the physical activity that you do, the stress that you take. Apart from all this, you have a wonderful drug that is vitamin D. Newborns who are deficient in it, your job is to write the correct dose and ensure that they take it. Thank you. That's my time.
Thank you. You were perfectly in time. We move on to the next session by our endocrinologist faculty, Dr. Nayana Vasireddy, and she would be talking on insights into vitamin D deficiency and toxicity. Over to you, madam.
Thank you, sir. So moving on, insights into vitamin D deficiency and toxicity. So I'm going to talk about the prevalence, which is already been told by Marwaha sir, at-risk population, who are the at-risk population for vitamin D deficiency, skeletal and extraskeletal manifestations of vitamin D deficiency, and the recent Endocrine Society guidelines on vitamin D deficiency. So, and the vitamin D toxicity. Okay, so now coming to the at-risk population, that is including, this actually includes all of us as well. So you have the patients who are actually on anticonvulsants or who are on ritonavir, who are on anti-HIV medication. So all these patients are actually on at risk for vitamin D deficiency because it actually accelerates their metabolism of vitamin D. So limited effective sun exposure, that is who wear fully clothed and who are on who use sunscreens for protection and other things. These people are also at-risk population. Then malabsorption, including inflammatory bowel disease and celiac disease. These patients are also at-risk population. So action of vitamin D at the skeletal and extraskeletal effects have already been iterated. So I'm moving on. So coming to the skeletal manifestations of vitamin D deficiency. So the first thing is this vitamin D deficiency. So what does that do? It decreases calcium and phosphorus absorption. So, and then you develop a secondary hyperparathyroidism. What does the PTH do? So the PTH does phosphaturia and bone demineralization. So actually what sir had previously mentioned was the bone plate, the mineralization plate actually widens, and that widening is actually because of phosphorus deficiency rather than calcium deficiency actually. So phosphaturia and bone demineralization. Then you develop, if it is severe vitamin D deficiency and you have severe phosphaturia and calcium deficiency, you tend to develop rickets and osteomalacia. Now coming to rickets has already been discussed. Hence, I'll be moving on to osteomalacia, which is the adult disorder. So osteomalacia is a bone disorder characterized by decreased mineralization of newly formed osteoid at the sites of bone turnover. So it presents as a bone pain, proximal myopathy, plus or minus waddling gait. So usually these proximal myopathy is pronounced, but waddling gait is more pronounced when you have phosphaturia and you have osteomalacia because of that, like how we have in TIO. You have fractures, you have deformities in the form of kyphoscoliosis, which was already mentioned. So coming to the evaluation part that you need to do, you have to do a calcium, you have to do an albumin, because you always have to do the corrected calcium of the patient. Then you have to do a serum phosphorus. This needs to be done in fasting state, because when you eat postprandially, what happens is there's an insulin secretion. So because of this insulin secretion, the phosphorus becomes intracellularized. So hence your phosphorus is always meant to be done in fasting state. Then you can do an alkaline phosphatase. Alkaline phosphatase will actually give you it's actually a bone turnover marker. So alkaline phosphatase being high, which means that bone turnover is high. If you have alkaline phosphatase low, which means the bone turnover is low. So this is how we can roughly say that the bone turnover is high or low. Then you can do a urine calcium. You can do a 25 hydroxy vitamin D, which is the storage form, and it is the most common form, but Marwaha sir will be talking on more about this. Then the creatinine, then the electrolytes. So coming to the, I'm sorry about the, I think there was some issue, but here what I wanted to illustrate was the loser zone. So if this is working. Pointer. Yeah. Yeah. What I want to focus.
You take the mic, so you will have to.
You can't see. Yeah. So how do I? Yeah, I'll use the first. Okay. So basically, this is a loser zone, which is actually a radiolucent line, which has on the sides, you can see the sclerotic bone on the sides. So this is basically a loser zone. This is typically bilateral and it's usually symmetrical. So if you have a radiolucent line, which is usually 2 to 5 millimeters in length, and then you can have a sclerotic bone on either sides, and it's usually symmetrical and bilateral, then you should always suspect loser zone. If you have a loser zone and you're seeing that there is alkaline phosphatase being elevated, then you're 100% sure that you're dealing with somebody who's having osteomalacia. So in these cases, you have to supplement vitamin D and calcium. Remember, vitamin D supplementation does not end with just vitamin D supplementation. You always have to supplement calcium along with it. Okay. So then the treatment part of it, vitamin D supplementation needs to be done. So 50,000 international units once a week, followed by maintenance dose. Calcium to be supplemented along with it. Always remember that. Now, Strauss therapy. So this is basically something that was previously being done in patients who were non-compliant. So in these patients, what was given was 6 lakh international units IM, a single dose was given, and a maintenance dose of after 3 months, you're giving 400 international units per day. This was discontinued because of risk of hypercalcemia, variable responses, and better alternatives that Pulse Pharma has already talked about. So coming to the extraskeletal manifestations, which Marvaha sir has already touched in, this is just a brief thing: immunity and autoimmunity, anti-proliferative effects. And you also use it in psoriasis and ichthyosis, which sir has already mentioned. Proximal myopathy, why does it happen? Multiple sclerosis is something that has not been covered so far. So I'll just say 2 things about multiple sclerosis. So it has been shown that memory and other things, like actually the neurons and everything also have the vitamin D receptor. So hence your vitamin D deficiency can actually cause Alzheimer's, and it has been linked to, vitamin D deficiency has been linked to multiple sclerosis. However, RCTs done with vitamin D supplementation have not shown improvement, but still there is a gray area. They're saying that the multiple sclerosis, you should have an ideal vitamin D to have a good effect. So coming to the Endocrine Society 2024 guidelines. Sure. Sure.
Okay.
RCT, yes, sir. Mm. 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 Mm.
Results for multiple sclerosis. That's the only autoimmune disorder so far
which is
proven that vitamin D works,
Yeah.
not that it doesn't.
Yeah, okay, sir. So then coming to the Endocrine Society guidelines, there are 2 papers that have been published recently. One was in the July edition of JCEM, and the other recently in this month in Endocrine Reviews. So coming to whom to test, they have specified here that conditions in which vitamin D status should be evaluated, that is the at-risk population, that is age above 50 years or a low sun exposure, sunscreen usage, where there is a lot of air pollution, which is in India, basically. Then you have a dark skin phenotype, which is again us, basically. Then again, you have the season and the latitude. That is, if you're coming from a high altitude places, or if you're from the areas where there is lesser sun exposure, then those people should be screened. Then in clinical conditions like obesity, morbid obesity again should be screened, and conditions in which should be evaluated due to reduced intake. That is, the people who do not have access to fortified milk or fortified products. These people should again be tested. Then again, who have restrictive diet, that is the people who do not use fortified foods like milk and all and curd, when they do not use and they're using restrictive diet, then there as well, you should be able to screen these patients. And again, if you have a bone mineral density problem that you're suspecting, then in those patients, again, you have to test vitamin D. Now coming to whom to treat. So they have defined that empiric treatment is needed from 1 year to 18 years at 600 international units per day. And if the age is more than 75 years, 800 international units per day. Pregnant women, again, 600 international units per day. And pre-diabetic patients, 600 international units per day. So coming to pre-diabetes, they've said that 15% reduction can be attained when the patients are on vitamin D. So, and the rest of the patients whom to treat, it is actually individualized and it is per patient basis. So how to treat the patient? So like it was previously iterated before, daily doses are more effective, and once yearly 5 lakh international units did not show fracture reduction. That was already mentioned. So in morbidly obese patients, treat with 3 times higher doses that are required. Then weekly may be given, that is the initial dose, may be given weekly, followed by daily doses can be given as a maintenance dose. Oral preferred, oral formulation should be preferred rather than parenteral formulations. Parenteral formulation should be given only in malabsorption, compliance issues, or if the patient is having pancreatic insufficiency or a post-bariatric surgery patient. So coming to vitamin D toxicity. So vitamin D toxicity, risk of toxicity and acceptable levels. So vitamin D levels, absolute level more than 100 may indicate risk of vitamin D risk of vitamin D toxicity. So to call it as vitamin D toxicity, you should also have ideally the hypercalcemia. So the hypercalcemia it can be present, and it can also have hypercalciuria, and you can also have hyperphosphatemia because it causes both calcium and vitamin D reabsorption. So risk factors for vitamin D toxicity is anybody who's having an exogenous vitamin D intake and who's taking more than 4,000 international units. Up to 10,000 international units also has been told by some societies, but more than 4,000 international units you have to keep in mind. Or if the patient is having granulomatous diseases, that is, if you have a granulomatous disease, you already have the alpha hydroxylation sitting there in the granuloma, which means that when you're giving supplementing vitamin D to these patients, then it converts into active vitamin D, and then it can actually cause vitamin D toxicity. Then taking fortified foods with supplements. You're already taking supplements, and on top of that, you're also taking fortified food. So that also can actually cause vitamin D toxicity. So vitamin D given as treatment, like how sir has mentioned for ichthyosis, he has given 35,000 international units per day. So in those patients also you can, and he has also mentioned the things that he's avoided, like calcium supplements were avoided, and other forms of vitamin D was avoided, and other calcium supplements were avoided. And whatever he was asked to hydrate the patient. So with these things, he has avoided hypercalcemia, but in the patients who do not know and who are not at the right endocrinologist may not know these and may end up with vitamin D toxicity. So risk of toxicity and acceptable levels. So again, if you see 83% are actually normocalcemic, even though the vitamin D levels are more than 100 and more than 88 and more than 150. So coming to that risk of toxicity and acceptable levels, if you see there were other studies done in Mayo Clinic also in 2015 showed that the incidence of 25-hydroxy vitamin D levels above 50 increased significantly between 2002 to 2011, probably because the extraskeletal benefits of vitamin D supplementations came into picture at that time. So this study was important for the following points: a significant positive trend from traditional 30 nanogram per ml in 2002 to 50 nanogram per ml and 80 nanogram per ml in 2011. Also a positive trend, although insignificant, towards the incidence of 100 nanogram per ml. An increase to 50, 80 or 100 nanogram per ml is not related to any hypercalcemic toxicity. Only one side effect was reported, that was also at an abnormal level of 364 nanogram per ml. So even though you say that vitamin D toxicity is there, that we're suspecting that vitamin D is more than 100, always do a calcium level before you say that this patient has ended up with vitamin D toxicity. Okay. So I'm sorry, but this, I'm not sure why this has occurred in this slide. So coming to the symptoms, you have acute symptoms and you have chronic symptoms. So when you have acute symptoms, you have confusion, polyuria, polydipsia, anorexia, vomiting, and muscle weakness. This is the acute symptoms of vitamin D toxicity. Coming to the chronic symptoms, which I think nephrologist has already mentioned, that you can have nephrocalcinosis and you can have CKD also, and AKI developing on top of that. Then bone demineralization and pain, band keratopathy, hearing loss, and painful periarticular calcinosis. So these are all the chronic symptoms of vitamin D toxicity. So coming to the treatment for vitamin D toxicity, you have to stop all forms of vitamin D supplementations and calcium supplementations. You have to IV hydrate the patient. And one thing that we have to remember is you have to first ask what kind of vitamin D was it. Was it calcitriol or was it cholecalciferol? Because if it's cholecalciferol, even though the half-life is hardly like around 4 to 5 days, but however, because of the adipose tissue, it gets stored in the adipose tissue. Hence, the release is slow and the toxicity lasts for few months. So hence, these patients usually require prednisolone or bisphosphonate therapy when the calcium levels are really high. But however, if it is if it is calcitriol, wherein the half-life is only 5 to 8 hours, if you hydrate the patient for the first 1 to 2 days, and the vitamin and the hypervitaminosis subsides, and your calcium levels come down to normal within 1 to 2 days. So hence, the type of vitamin D supplementation that the patient has taken also will make a difference. Okay, so now the indication for steroids, that is prednisolone or hydrocortisone, can be given. Prednisolone 20 to 40 mg per day can be given, or IV bisphosphonates can be given. So the indication will be that if you're having a granulomatous disease or ingestion of cholecalciferol. Thank you, Amber.
Thank you. Thank you. So, friends, we really know the round 360-degree overview from the different perspectives we could arrange to get into the insight of osteoporosis. May I request the panelists to come for the panel discussion. Friends, we have learned so many things about osteoporosis, vitamin D, calcium, and our thought process has really been changed with it. Now, there are a lot of questions which would be there, we would be discussing over here. So friends, those who are leaving, just let me remind you, it's going to be a very short time before we wind up. We would be briefly taking up few questions. Here it reminds me the beautiful quote from Sir Alvin Toffler, who states that illiterate of the 21st century are not those who cannot read or write, but those who cannot learn, unlearn, and relearn. And that's how we all are here today, to learn and unlearn and relearn so many new things, especially with vitamin D. So may I invite all our distinguished faculty to please come on the stage. First, please give a big hand to these distinguished faculties who done a marvelous job giving with the time taking. They have done an excellent job. So we must compliment each and every faculty over here. We would give them the mics. Okay. So I would, yes, request Dr. Harsh Chaturvedi to please come on the stage also as one of our panelists, because there may be questions bombarded at you also. So we will come to Dr. Marwa, sir. Sir, can you throw some light about the high dose vitamin D supplementation and your experience, because you have the vast experience about it. So can you throw some light on that?
Not that I have vast experience, but it was by chance that we learned that it works, because this congenitally, I'm not a pediatrician, so, but the skin dermatologist wanted to work with me on vitamin D. And one day he calls me when he sees those congenital ichthyosis. And can you hear me at the back?
Yes, sir.
Okay. So he said that there is a child who's got this, sir, why don't you come? How much dose should I give? So I saw that child and I said, he also has rickets. So I said, you give him 60,000 every day for 10 days. So he said, sir, you get me sued in Knowledge Institute and I'm not going to do it. So I said, no, you quote my paper on rickets. The child has rickets. You don't say you're treating for congenital. You give 60,000 for 10 days, 6 lakhs units, which we give for rickets. And then see. And 7th day, he calls me in the All India Institute OPD. He says, sir, please come and see. And he shows me, he said, do you recognize this child? I said, no. So he said, sir, he's the same child whom we gave this. So the point is, we learned it out of this, not that I knew about how to treat congenital ichthyosis, but I was very firm. Please remember, like how active vitamin D is formed. Skin is a complete organ by itself. It forms from vitamin D3, 225 hydroxy and 125 in the epidermis cells. So this is a complete. We have seen with all keratotic lesions. You can try it in your OPD. All skin keratotic lesions, you will see wonderful impact if you give short duration of high dose followed by maintenance. And this is by the dermatologists I'm talking of. So since I'm not, so I can't comment, but I have shown those patients to dermatology. Now they are convinced at All India Institute, he is totally convinced, gives high dose. But what has been shown is that it works on innate immunity and adaptive immunity. That is proven. We have shown in last 2 of our papers very clearly how T helper cells or T regulatory cells, how anti-inflammatory, all those things have been shown by us and others. So ours was just a recent work, and the purpose that we worked was, basically I gave a concept that high dose of vitamin D may improve efficacy of COVID vaccine, which was not there in the world at all. So we gave 25-hydroxy, not vitamin D3, for the simple reason we wanted 25-hydroxy levels to be high immediately. Vitamin D3 would have taken few weeks for it to achieve. And we wanted to give vaccination and then see all this. So it turned out to be that, well, the work was worth it, and we had 4 publications out of that, clearly showing that it works in improving the efficacy of vaccine, which can be used for other vaccines. So keeping, I'm not saying keep very high levels, but at least maintain above 30 to 40 to at least improve the efficacy. The only other thing, see, most of the randomized trial recent have not shown benefit in extraskeleton. But then there are a lot of confounding factors why they have not shown. The post analysis of subgroup, see, most of the trials which have been done, the patients already have more than 20 nanograms. So obviously you would not see the effect. Most of the trials have not measured maintenance of 25-hydroxy D. So when they did post-hoc analysis in subgroup which had low vitamin D, in pre-diabetics, prolonging their going into frank diabetes has been now beyond doubt. The reduction in conversion is about 10 to 15%, as she mentioned very clearly, from 23 to 20. And Peter's 2 studies also have shown and proven that it works in prolonging the conversion of pre-diabetes to diabetes.
Right.
Also been shown. The other thing which has been proven in this is multiple sclerosis, and that is by Mendelian randomization. That is gold standard, not randomized. That means those who are genetically have got low vitamin D, the prevalence of multiple sclerosis is very, very high in both young and elderly. So these are been proven, but we have a lot of things to learn as to what is that cutoff level which will do this, what is that GIT also has. Now, the recent thing is that those who have antibodies to P53 protein, if you give vitamin D, it prevents GIT tumor. And proven very clearly now. So I think we are still in the learning phase. We can try so that patient don't go into hypertoxicity and things like that, but under supervised.
Yeah. So there has been, of course, during the COVID time, the people have tried high dose vitamin D for 5 consecutive days, 60,000 units, which has been used. And in fact, they have shown they had a better outcome also. But these are all off-label indications, usage, which is there. But there has been usage of it. Now, here I will come to Dr. Chaturvedi. Now, you have been talking about the nano. And here we are not talking about the morning I came by nano car, but we are talking about the nanoscience, nanomolecule, nanotechnology, how these are different when we are talking about vitamin D formulations.
Thank you, Dr. Mehta. I hope I'm audible.
Yes.
So, well, nano can be nano car, which was there by Mr. Ratan Tata, and a deep project. It was really small and though comfortable, but not very efficient in certain aspects. Nano, when we think about it, we think about size. Size does matter, yes. But here When my company, my organization, we talk about nano, we are talking about a delivery system. We are talking about science. We are talking about not creating a nano particle by just adding a surfactant to the system and making the oil solubilized in water. That is what is generally you can do. So we make a missile which are nano sizes. They can be 50 nanometer, they can be even less than 50 nanometer. But when we talk about nano, we are talking about dissolving the vitamin D in a phospholipid carrier, then making the nanoparticles out of it, covering the surface of each nanoparticle with a hydrophilic polymer, which ensures the transportation in the body. And the surface of each nanoparticle is decorated with ligands, which ensure that the vitamin D is not degraded by the GI pH variations. It is not degraded by the enzymes which are present in the gastrointestinal tract, and is also stable to the degradation from sunlight and oxidation. And that is why when my MD was talking to you in the early part of this program, he said we are the only people who have a shelf life of 3 years. No other vitamin D, believe me, across the globe has a shelf life of 3 years. They do not even have 2 years. Most of them, they generally have 1.5 years. So nano is about delivering the vitamin D safely and efficiently to the organism. So it's not just a size, it is about a delivery system. That is what it is. That's first thing. Second thing, I'm speak a bit more. When Dr. Marwa was deliberating on the high dose vitamin D and the COVID, we with Dr. Lucky Reddy here, that time he was on Nizam's Institute, we did some work on mechanical low back pain, and we used the doses of 60,000 international units every day for 10 days. And we realized that the levels when we were achieving on 21st day were to the tune of about 96 nanogram per ml. The patients were 100 patients, adults who were experiencing mechanical low back pain. None of the patient had any issue with like hypercalcemia. There was no reduction in the PTH levels. They were everybody happy. And we realized that the higher the level was, the greater was the reduction in pain intensity and other disability index. So it's, I don't say it's a myth, but I think we have talked about it many times, and we realized that, really, is it 100? Is it 150? Does it really manifest like that? So then subsequently we did work on COVID, and we realized that higher levels are required. When we compared our work with the work which was done at PGI Chandigarh, the SHADE study, they stopped at 50. They didn't get any reduction in the inflammatory markers. We went on substituting and supplementing. We reached a level of 85. We had interleukin coming down. We had CRP coming down. We had, ferritin coming down. We had D-dimer. We could not manage at that time. So yes, somewhere you really require levels which are much higher. It is believed earlier that 30 was adequate, 35 was adequate. But now we are looking at least at 40 to 60 kind of a thing, and maybe more than that. And really, as far as I know, you are clinicians, you understand it better, but I don't think hypervitaminosis or hypercalcemia manifest at even a level of 150 nanogram per ml, right? So again, coming back to nano, we know it's tough. It is a delivery system which has to give you the drug adequately and safely. And that's when my MD mentioned that even in US, you only have 20 nano drugs available. It is difficult to design, right? And what, by designing this nano system, we have achieved is a predictability and a consistency of the results, a consistency in the outcomes. You see many studies, they're giving X amount of vitamin D. They don't get benefited, whether we talk about PCOD or something else, wherever it is. So some say it works, some say it not works. It's about achieving the levels and adequate levels. And I think, yes, one has to be cautious, but there's nothing to fear. and giving such high doses. That's what I would like to say. Thank you so much.
Okay, so now you mentioned about low back pain. I would come to Dr. Kakatkar, sir. What is your experience of using pulse high dose vitamin D? Because you must be getting referrals for being a senior orthopedic surgeon, and patients are looking at you to give something, early relief and give at least some relief. So what is your take on that, sir?
Well, we do get back pain patients, and we try to first analyze, what is the real cause of back pain, because it's a multifactorial problem. We have to understand what is the degenerative process which is responsible for the back pain. If there is any deficiency, we try to get the investigations to find out whether the patient has deficiency of vitamin D. And depending on the etiological factor of back pain, one or more, accordingly we plan our treatment. If the vitamin D levels are normal, then there is no point in giving a high dose of vitamin D either on daily or weekly basis to these patients. If somebody is having deficiency, then yes, we do recommend. And normally, instead of daily, we usually recommend initially weekly. And we have found that the outcomes are very good. If they are deficient, by supplementing with vitamin D, the back pain definitely improves very dramatically within 3 to 4 weeks' time.
Okay. So in corollary to this, I would come to Dr. Rajesh. Now, you mentioned very beautifully about the association with fractures and you find the vitamin D. So somebody who is presenting with the fractures coming to you, due to whatever maybe the etiology may be. So do you get vitamin D levels tested in each patient? One. And second, if not, then do you treat empirically all patients with vitamin D or what?
Yeah, that's a good question. So routinely, we don't get vitamin D checked in all the fracture patients, number one. And also depending on which patient is presenting with the fracture. So if it is a young and healthy patient who has come with a fracture versus an elderly patient coming with a fracture neck or femur, for example. So we know most of the elderly patients are insufficiency fractures, while in a healthy patient, it could be because of trauma or anything. But as we have seen in the literature as well, the prevalence of vitamin D deficiency is there anyway in all these patients, up to 95%. So see, we know the role of vitamin D in bone health. So by default, no harm in giving them vitamin D supplementation anyway, regardless of whether they have whether to treat the fracture per se. As we have clearly seen in most of the literature, that vitamin D itself is not going to prevent non-union as such. It has to be supplemented with calcium, if at all, especially in the elderly. So by default, we can give vitamin D, like 6,000 international units or 800, as recommended, 800 to 1,000 international units per day. It's okay because it's not going to do harm, as it will improve the bone health per se. For that reason, we can give. So, and these patients who have a good vitamin D, in future, their rehabilitation will be good, muscle strength, because it also helps with the other aspects as well, not only just the vitamin D. So for an overall improvement of their general rehabilitation, yes, vitamin D is given, not as such for preventing non-union of a fracture per se as such. Okay. So for that reason, yes.
Right. I would come to Manjula, ma'am. Of course, you mentioned about how the women are at higher risk and all. You mentioned all the risk factors and all. Now, how much stress would you give to the nutritional aspect, especially in a post-menopausal woman with osteoporosis? Because women, we have seen typical in the lower strata or in the middle strata, the lady usually takes whatever bacha kucha ghar pe, that is what the continue. Of course, picture is changing. We see at equality, but still, nevertheless. So that picture. So how much stress would you put on nutritional component, ma'am?
Thank you, sir. So I think, like we all agree, that vitamin D deficiency has become a pandemic. It's rather than an Indian population per se, I think, are vitamin D deficient. So when we look at how do we give it as a supplement, or are they going to take nutrition, we always talk about balanced diet. It's very easy to tell. Acha khao, balanced diet, balanced diet. What exactly is the balanced diet is what people find it very difficult. We do know we are looking at vitamin D plus the calcium. So calcium curds, fine, we all will take up. And then what happens is the paneer, tofu, or these are some things which we keep telling because high protein is needed, high fiber diet is needed. We need magnesium along with calcium. Again, we don't want any constipation which is going to come. And apart from it, we also spoke about how the fish, which is very important when we talk. But is it easy for them? Because we always talk about sunlight and is it easy? I don't think any woman want to go and sit in afternoon, 2 o'clock, 3 o'clock sunlight and becoming dark and then having the sun toxicity and everything. So I think diet is one aspect about it. Bacha kucha nahi hai to bhi everybody wants to eat healthy diet, balanced diet. That is very, very important. We have to look at the balanced diet, fiber, decrease alcohol and caffeine, which we already spoke about how osteoporosis can worsen because of it. And also supplementation is what we should be looking at.
Yeah. So you said rightly all those factors, and that has been taken care of so much because that's why we did not give a tea break. So caffeine intake can be reduced. Physical activity, we did it. They have taken care, no alcohol, as you rightly said. And in this auditorium, smoking is not allowed.
Completely.
So all factors have been taken care of. Few of my friends who wanted to had to go out and take some, yes.
Take it.
So that's have been totally, these factors have been taken care for all the aspects. I would, yes, sir.
Well, as far as the deficiency is concerned, in spite of the adequate sunlight, I think there has been work done by the IIT people.
Sir, our skin does not absorb only.
No, it has been found that when they developed the apparatus to measure how much ultraviolet reaches up to the surface, they found that because of the pollution, even in the rural population where people are working without much clothes in the fields, in sunlight, still they have deficiency. And it has been proved that because of the increasing pollution, the incidence of vitamin D deficiency is increasing very rapidly in our country.
Yeah, so that paradox which has been seen, though we are in the temperate climate, we are tropical countries, and still with adequate sunlight also, we have a large population which is vitamin D deficient, which is there. Okay, I would come to now from the pediatric perspective. Sir, you want to say
Can I
something?
make a point on what? So this is not the IIT guys. You see, we had carried out studies both in summer and winter. Winter is when there's a lot of smoke, and we had measured UVB rays across the country, south, west, east, north. Everywhere in winters, the UVB rays are so low. And when we expose children for 1 month out in the sun between 11 and 1, which is the best time to expose, which we had shown, in winters, there was no formation of vitamin D at all. In fact, it went down because of whatever was available was metabolized. And in summer, extreme summer, these are both international papers I'm talking of. First human trials ever done in the world is by exposing these children for 1 month every day for half an hour with 10 to 15% body surface area exposure. In the month of June, they formed only 4 nanograms. So it was, if it was 10, we had that to 14 nanograms per ml. So despite so much of exposure, you really did not form adequate vitamin D. That is which I was wanting to say. So winter, cut it out at least 3-4 months, you will not form vitamin D, at least in the metropolitan cities. I am not talking of villages, but even in villages, the levels have been reasonably low.
So here we know that vitamin D is close to summer and not winter. So that is one thing which is there. Okay, from pediatrics point of view, Sri Krishna, would you, how safe intramuscular vitamin D in patients with rickets, or you would depend on oral preparations?
So, oral preparations, to keep it very short, oral preparations are much preferred. Only when you know that you can't give oral preparations, whatever be the concerns related to absorption or the availability, and only in certain conditions would we take IM injections. And pediatrics, the branch is such that we would like to use the least medicine in the least harmful way. So even with that in perspective, we would still would not prefer IM injections as the first option at all.
So what you give will be the only oral, which is
Yes.
which will be there.
Shri Krishnan, I'd like to differ, though he was saying there's hardly any compliance. We just finished a project at Maulana Azad. We have earlier 5-6 papers on rickets, what to treat. Initially, when we started off with intramuscular, compared it with oral, 6 lakhs with say 60,000 for every week for 10 weeks, equivalent to 6 lakhs. Both were equally effective. So intramuscular is very effective. Number 2 is very, very cheap. Within 60 rupees, you can treat rickets for 3 months. But thirdly, the most important thing is that the compliance, even rickets patient, we had such problem with the compliance when we were giving free medicine, the nano, this thing, that we had to redo so many of these patients. So as you showed, 29% compliance with oral vitamin daily taking is a problem with normal, at least children or from families in the poor background. They really don't bother much. So best is give 1 injection and they will be cured. So I think for our country, I'm going to write that in fact officially, because everybody is saying don't give intramuscular, don't. But for our country, for poor country, and those children, they can't afford. And secondly, even if they can't afford, there is a compliance problem in this country.
Yeah, I would, sir. Yeah, sir. I think now we would request quick if we have to pass the comment, sir.
See, there in my talk, I had referred to one paper that in obese patients, they have done a study that if you give intramuscular vitamin D and if you give oral, the results are much better with oral, because whatever you give as a deep intramuscular injection goes into the fat layers in obese patients, and the levels achieved after giving injectables are much less than giving oral.
Yeah, Harsh. Yeah.
We have recently concluded a clinical trial in patients with chronic low back pain, where we have compared 6 lakh single injection of vitamin D versus 60,000 IU every day for 10 days of vitamin D. And what we have realized, and I was grilled by the drug controller and their committee, that how can your oral vitamin D can have a higher level than the IM injection. It's very well documented, ladies and gentlemen, that injectable vitamin D intramuscular takes 3 to 4 months to peak, and it's still at lower level. You get a much higher level with the oral vitamin D. And I believe, if I'm not wrong, Dr. Raju will add to it, that now even the kidney associations do not recommend using of intramuscular injections. They say that for nutritional vitamin D is the first thing, and the one which always be used. So probably, and I can, Dr. Kakatkar can correct me also, the incidence of hypervitaminosis and hypercalcemia has only been seen with injectable formulations and not with the oral formulations, irrespective of the dosage. I can be corrected if I'm wrong.
Yeah, I would here only come to Dr. Raju. So, as mentioned, for CKD patients, or where that is the one indication for giving active vitamin D formulation. So would you give in every patient just the only active vitamin D formulation only?
Right from the beginning, when the GFR is falling from around 60 and less than that, we start supplementing active form of vitamin D, that is calcitriol. So then, despite that, the PTH will not so easily. Good number of these patients will have an subtle vitamin D deficiency, which also should be supplemented initially itself. And our patients will get a vitamin D deficiency very frequently because they don't get exposed to the sun and they don't eat well. And they'll be depressed and they'll not be doing any physical activity as such, as the creatinine goes up and as the GFR comes down. So that's why, other than the active vitamin D, that is called the calcitriol or calcidiol, but which there also did some study, and also the 125 dihydroxycholecalciferol also will be supplemented in these patients so that they can have an adequate amount of bone strength. The bones are very important in our group of people, where it is basic architecture, and also that keeps them well. Even as I stored in, even beyond transplantation, they'll be having some kind of a bone deficiency or bone disorders after successful transplant also.
Okay. So now we have been talking about various levels of vitamin D. So I will ask Dr. Nayana, what should people measure? There was a time, a decade back, there were hardly any labs who were doing vitamin D, and you had to send it to very specialty labs. And now they will ask whether you want total vitamin D, whether you want 25 hydroxy D3, whether you want 125 dihydroxy D3. So can you tell our delegates what should be the ideal thing to be done?
So, so the thing to be done is 25 hydroxyvitamin D, which is the storage form of vitamin D. So that should be enough. And coming to the measurement of vitamin D itself, the assay reliability is still under question. And LCMS is the best way to measure vitamin D, but however, LCMS is not available everywhere. So hence, when we are measuring vitamin D also, there may be assay variability as well. So the thing that we measure is 25 hydroxyvitamin D. It is a storage form. It is the one to measure. There are indications, specific indications to measure 125 vitamin D, wherein when you're suspecting hypercalcemia related to granulomatous disease, in that case, you can measure 125 vitamin D. Like that, there are a couple of other indications. However, due to interest of time, I'm not mentioning those. So hence, yeah, sorry. So that is what I would like to say. Marwa, sir, would you? Sorry.
No. No, sir, no, sir has already covered that topic. So I think what all the panelists have wonderfully given us the brief outline about all the concepts, doubts which we were having it. Let me just tell a couple of points over here that when we are talking of vitamin D levels and what right from our first presentation, Marwa sir had presented very well. What are we looking at it? So there is first thing is whether we are looking at bone health, where by all organizations now we are targeting 30 plus. If you are looking at metabolic health, where we are looking at the vitamin D relation with the various NCDs and which the data which is showing, we are looking at targeting at 50, which is the one which will have a better health. And then there is something called as immune health. So if you are targeting immune health, you still require much above that and the levels at even 70. And what Madam has already shown beautifully that we are seeing more and more number of patients. So especially if you are talking about in rheumatisms, collagen vascular disease, where you require a higher levels, which has been done. Talking about hypervitaminosis D, which we have seen that what Madam has shown the paper, the levels when it was 360 plus, and that was the time it was showing manifestation. So remember one thing, whatever the lab values which has been shown, that would, once you get that level above it, it only mentions biochemical hypervitaminosis D. It does not correlate with clinical hypervitaminosis D. And clinical hypervitaminosis D is very important because the person need to have symptom. If somebody accidentally comes to you with that level of 105, would you treat it if the patient is asymptomatic? No, just stop vitamin D at that point of time. Secondly, your hypervitaminosis D is going to happen only and only if the person has taken repeated intramuscular injections, which used to happen. I am sorry, my orthopedic friends are here. The orthopedic surgeons earlier were very fond of giving intramuscular injections, and that I know, sir, you may not be, but all your colleagues were so fond of giving IM injections, and probably right from pediatrics to all the medical subspecialties have especially been, because we have got such a fantastic nano which is available with us. Why go for it? There is no need, and you will have a better bioavailability, better absorption without having a painful injections. So we need to take care of it, that we talking about the clinical hypervitaminosis D versus biochemical hypervitaminosis D, and that is needs to be differentiated. So please give a big round of applause to this, the wonderful panelists. Let me tell you, this is a hybrid event. We are on live also, and at present 305 delegates have logged in. So probably they are much more than is. I am promising on behalf of Pulse that they would be getting virtual dinner also after the event also. So may not be physical, but they would definitely get that virtual dinner over here. So ladies and gentlemen, please give again a big round of applause to the panelists. And I would like to hand over back to Pulse Pharma for the final ending ceremony. Thank you.
Sir, can I add one point, sir? I'm an orthopedic surgeon.
Yeah.
Most of the patients who come with a low backache or fibromyalgia, something like that, the first thing I do is no X-ray, a thyroid stimulating hormone, and vitamin D. 95% of my tests are positive, hypohidrosis. And as you said, I'm very fond of injections. Okay, so I give 1 or 2 shots of vitamin D, and after 2 weeks they come. They say, doctor, but you said that it takes 3 months or 4 months. I'm sorry, I'm not agreeing with you. After 2 injections or 3 injections, I mean, in a matter of 6 weeks, they say, doctor, without painkillers, I'm doing very well. That's what I have noticed that. And the second thing about the farmers who work on the soil, from morning 6 to evening 6, they come, their vitamin D level is so low, is as low as 8. Because most of them, I find their skin is very dark. The melanin the melanin prevents the absorption of the vitamin D. That's 2 reasons what I noticed. And I mean, and nothing against nano, something like that. They do well, they do recover fast with injections. That's what just I want to convey the message. Thank you.
Thank you.
Wanted to just ask one question to all the panelists. Where this logic of weekly dosing of vitamin D3 came? What is the logic of weekly dose? Why it should not be daily dose? Even if it is high dose vitamin D3, daily dose. The same 6 lakh IU or 3 lakh IU what we give, instead of giving weekly, why not we just give it on a daily basis?
High dose is always given once. If you give 6 lakhs, even for rickets, forget about normal subclinical, even for rickets, when we first gave, earlier days, pediatricians used to give 6 lakhs. So I also started giving 6 lakhs to see how it works. It worked beautifully compared with similar dose of oral, which was 60,000 every week for 6 weeks, 6 lakhs. Both of them equally effective. 95% of the children healed with both of them. The levels of vitamin D were similar, and there were no complications with vitamin D. With injections. The only problem is slightly painful. But we have poor patients who are getting. This is the only country which still has rickets patients going around, where other countries you don't see rickets patients. So I think if you give 1 injection and send them back home from the hospital, but when you give, now the studies, long-term studies are very clearly shown. If you want to take benefit of vitamin D, that means in terms of prevention of cancers and prevention of upper respiratory tract infections or any other, daily dose is the ideal dose. So it is not high dose or something like that. What I'm saying is, instead of taking 60,000 once a month, which is 2,000, if you say so, it is not correct, then it will be much better. Now it has been proven beyond doubt that daily or weekly, monthly dose doesn't really help in extraskeletal benefits. So daily dose, physiologically also, whatever is your daily requirement, you should take daily. Correct. Why should you take once a month?
Correct.
So it's a normal logical thing.
To the question, but the point is primum non nocere. We are here not to cause anything. So safety is the main thing. So we do not want to create any hypervitaminosis. What is the safest level? 60,000 weekly ones. So we give 60,000 weekly ones. Daily, if you want to give, you have 4,000 units, 2,000 units, which we want to give. So this is what over trial, over periods. So we don't have to jump and give high dose for it.
Okay.
Because it's fat soluble. There are only few vitamins which are ADEK and which can cause hypervitaminous where we are worried. Vitamin B12, if it is more than 2,000 also, we are not worried. Next, within the urine, it will go. So we should always look at safety.
From that angle, so you want to give.
Yes. Thank you.
I know people are so enthusiastic about vitamin D also. So we don't get vitamin D toxicity easily, but if we continue, vitamin D discussion toxicity can come in. So let's give a halt over there. Thank you so much.
Thank you, everyone. Thank you, Dr. Ketan sir, for this wonderful session. I would now request Mr. Rambabu, sir, MD Pulse Pharma, to please come up the dais and address the forum, sir.
Dr. Bashir. Dr. Bashir. Bashir.